Good morning. Wow, we have a wonderful crowd here for the third in our cycle of the healthcare cost trend hearings. I think everyone knows that these hearings were legislated in the 2012 law that established the Health Policy Commission and sort of set a course for us in the state to keep our spending growth in line with the growth in our state income. And these 2 days are designed for us to essentially look under the hood, to get a better feel for the forces that are operating within the state, either to expand healthcare spending or more, hopefully, to slow it down to a level that the state can afford. And I'm really looking forward, and as my fellow commissioners, to these 2 days. I don't want to wait to the end because I really want to thank the staff and Executive Director David Sells for putting this conference together. I don't think I need to tell anyone in this room, but I will, how much work goes into putting an activity like this together. And I hope you will share with me the feeling that it was worth it. Again, thank you very much. I also really want to thank the powers that be here at Suffolk Law School. We had the opportunity of hosting this event last year, and we immediately put in our digs for it to happen again this year. I can't tell you how pleased I am, and David and Lois, in terms of the work and everything about this facility. So thank you very much, and you'll notice as we walk out, we have our digs in for next year. So we want. So for those of you who had trouble getting here, hopefully tomorrow and next year it'll be a little easier. And I would like now to have Professor Renee Landers come and say a few words. Professor Landers is a professor here at Suffolk Law School. She has a great career. She's currently the director of their health law concentration. But she spent a fair amount of time in Washington as the Deputy General Counsel for the U.S. Department of Health and Human Services and the Deputy Assistant Attorney General in the U.S. Department of Justice. And before that, she also had a stint here in Massachusetts as the Deputy Secretary of State in terms of their Commercial Bureau of Public Records. So, you know, Professor Landers is well versed in the complexity of our state and federal governments. And again, I want to thank her and Suffolk Law School for allowing us to use their facilities. So, Professor, thank you so much.
Well, good morning. After the first few speakers today, I'm sure you'll be very well welcomed to this commission hearing today. Professor Altman, thank you so much for those really kind remarks. And I know it is a tremendous feat of organization for the Health Policy Commission to pull off these hearings every year. But I do appreciate your acknowledgement of the role of Suffolk University and our really phenomenal event staff here who really help make events like this come off with the minimum number of glitches and disruptions which inevitably occur. It's also a great honor for us to host the Massachusetts Health Policy Commission and to have the wonderful panels and discussions that will take place today available so immediately for members of our community to participate in. Because we have this health and biomedical law concentration, which I'm privileged to direct, it is especially appropriate that we should make our facilities available for this important conversation. We're pleased to welcome Dr. Altman and all the members of the Health Policy Commission and the staff and the various officials of the executive and legislative branches. I had started to name a few people, and then I looked at the agenda and I realized that that was going to be a folly. We'd be here all day if I did that. But it's really, truly an honor to have the interest of people at these levels of government participating in this important discussion today. Also, I want to give a shout out to a lot of the distinguished health policy experts, knowledgeable representatives of patients and consumer organizations, leaders of the healthcare, insurance, provider, pharmaceutical, and device sectors who will be represented, whose views will be represented here at the hearings over the next 2 days. This annual examination of cost trends is a really very prescient recognition by the Massachusetts legislature that the goal of providing the right health care at the right time in an appropriate and effective manner will not be possible without controlling the costs of services for the employers, individuals, and public payers who must bear the burden of the cost. I also want to say that these groups of people who are represented here today are a group of people that we're especially grateful for here at Suffolk. As I indicated, the curriculum, the focus of our curriculum in the law school and the university on health law and policy and healthcare administration is really an important one, and I think our new president, Margaret McKenna, is very interested in emphasizing those fields even more. At the law school, we have a rich curriculum with resident faculty and adjunct faculty who bring a wealth of education, research, and practical experience to the learning of our students. Some of our students come from backgrounds in the sciences and health professions and make their own contributions to the educational process here. We also, as I mentioned, we are very grateful to many of you in this room because you have been kind enough to make internship and employment opportunities available to our students. Some of you are alumni of Suffolk. Mike Caljo, Blue Cross Blue Shield, has been, his organization has been very good about hiring law student interns and making permanent employment opportunities available to them. And I know that we have several of our alumni who work as staff members at the Connector Authority, excuse me, and even here on the Health Policy Commission, as well as other agencies in the state government and in the private sector employers here. So I'm very grateful for that. In addition, we have a number of co-curricular activities, a health law clinic, a journal of health and biomedical law, the health law moot court team, a health law society, and a health law policy speakers forum. And perhaps some of you have already been speakers for many of these programs, and I hope that in the future, if you're invited to speak on a topic with your own expertise, you will accept the invitation to come back and join us to help participate in educating our community. I think obviously it goes without saying that everyone in this room, perhaps everyone in this room, would agree that one of the great achievements of the last decade has been the enactment of the Affordable Care Act, creating the promise through the individual mandate and the Medicaid expansion of access to insurance for all people in the United States. Despite the efforts of lawyers to undermine some of the key provisions of the statute and the constitutional challenges, the challenges to the tax subsidies, and now the emerging challenges to contraceptive coverage, the achievement has been a quite substantial one. But even in the groups that have access to insurance, and not all, in some of the groups, some groups of people have been left out of that improvement. Access to care in a timely fashion may be more of a promise than a reality due to the capacity issues and the costs of deductibles, co-pays, and co-insurance, and the cost of insurance in some market sectors. Price transparency also is difficult to attain. Cynicism about the Affordable Care Act and our efforts in Massachusetts, pioneering efforts for universal coverage, will develop if we do not make these costs manageable for society as a whole and for individuals seeking care. The CHIA report noted the particular problems that remain with integrating mental and behavioral health services. As a recent patient and as the daughter of a of an elder who is, of course, having increasing encounters with the healthcare system. Everyone has a story. That's the thing about healthcare. Things like inordinate waiting times, practitioners who do not listen to patients, and as a result make errors in diagnosing injuries and conditions, and the myriad and mysterious bills that come from practitioners that patients aren't even really aware of being involved in their care, will lead to cynicism if some coherent structure is not brought to bear. I hear chuckles in the room here. So these deliberations today are really, really important because examining cost trends and how to structure care and the financing of care is really important to solving these issues. Thank you very much for all the work you will be putting into this process today. Thank you for being here at Suffolk, and I'm really glad to know that you'll be back next year. All right. Bye-bye.
Well, thank you so much. So as I complete my third year as chair of this group, I look around to my fellow commissioners. I feel how really special it's been to serve in that role. You know, I've learned in my few years of being in public activities that of all the different activities one can engage in is picking the right executive director. And I couldn't be more pleased with the relationship that I've had with David Sells. David and I did not know each other before this activity, but we've gotten to know each other pretty well since then. And so, you know, on average, we're about the right age to do this kind of job. You know, and no, I think back, David, to the beginning of our efforts where it was just you and I in that rickety old building. And then David said, you know, I'm going to do you a big favor. He said, I'm getting a general counsel here that's going to keep us both out of jail. And she's worked really hard to do that. Thank you so much, Lois, for all the activities you've done. So I'm now going to turn the podium over to our executive director. I think you all know him very well, and my friend, David Sells.
Thank you, Chair Altman, and welcome to the 2015 Cost Trends hearings. It is great to be here this morning for what promises to be a very exciting and engaging 2 days of remarks, testimony, and discussion about how best to advance a more affordable, effective, and transparent healthcare system in Massachusetts. This is the Commonwealth's 6th annual Healthcare Cost Trends hearing, the third hosted by the Health Policy Commission. These hearings are a good fit, are a public good, and fit squarely within the Health Policy Commission's mission to promote transparency, act as a convener, and shine a light on the Massachusetts healthcare system on behalf of consumers and businesses. Before we begin today's hearings, I'd like to make a few acknowledgments, then quickly preview the agenda and dispense with a few logistical announcements. First, I'd like to acknowledge the incredible dedication of the commissioners of the Health Policy Commission seated here before you. These extremely busy, accomplished professionals not only have cleared these 2 days to help lead this hearing, but have given up untold hours of their own time reading testimony, preparing questions, and leading the development of today's agenda. Your insights and your expertise, commissioners, have made this event the healthcare event in Massachusetts. As volunteer board members that serve without pay, your public service contributions to the Commonwealth is acknowledged and appreciated. Thank you very much. I'd also like to announce and acknowledge our partners in today's event. From the Center for Health Information Analysis, Aaron Boros, who we'll be hearing from later, as well as the Office of the Attorney General, Karen Sung, who's with us today. We'll hear presentations from both of their organizations over the next 2 days, respectfully. Thirdly, thank you again to Suffolk for hosting this event. This is a great event, and this is a great room to hold it in. And thank you again, Renee, for all that you've done. And finally, I'd like to acknowledge and thank you, this audience, for participating in this event, and for all of you who are listening and watching on the live webcast. In the 3 years that the HPC has hosted this event, this year recorded our highest level of interest in attending, with over 400 people registered to attend in person, and many, many more, not only in Massachusetts, but from across the country, who are following along on the live webcast. This is a testament and reflection of the importance of this issue. The public is engaged. The public understands that rising healthcare costs mean less money for state government to invest in education and transportation. It means less money for job and wage growth and less money out of pocket. And they are rightfully wondering if we can do better. They want a better healthcare system that coordinates their care when they leave the hospital. They want a better healthcare system that has access to primary care after hours and on weekends. They want a better healthcare system that fully integrates behavioral health and treats whole person needs, not just physical health. They want a better healthcare system that rewards providers not on how many tests and procedures can be ordered, but on the health outcomes that they achieve. They want a better healthcare system with transparent and actionable information on price and quality of providers in order to make informed decisions about where they seek care. They want a better healthcare system that supports innovation and new treatments and drugs, but at a price that they can afford. The public wants this better healthcare system for Massachusetts and would like to know what it will take to move us to that better place. We hope that these 2 days will begin to answer that question. A quick program review for this morning. We are delighted and honored to have with us the main elected leaders of the House, the Senate, and the governor, who will all be providing opening remarks over the next hour and a half. We will then hear a presentation from Aaron Burrows as the Executive Director of the Center for Health Information and Analysis on the state's performance in 2013 and 2014 on our total healthcare expenditure benchmark and other trends. We're delighted to have Dr. Amitabh Chandra from Harvard University, who will be giving a presentation about how Massachusetts trends fit into a national perspective. Then we're going to move into the heart of the hearing. We'll have 3 panels today with witnesses representing CEOs of our major healthcare systems and healthcare providers in Massachusetts. The 3 panels today will focus in first on our ability to meet that benchmark. That will be this morning, and then after lunch we'll have 2 additional panels of witnesses testifying and answering questions on innovative care delivery and moving our provider system forward, and then finally how we pay for that care through payment reform and changing to value-based payment, the focus of the last panel of the day. Following these panels, we will have public testimony available. If you would like to sign up outside, please do so. A few announcements. We do have free Wi-Fi. Yes, free Wi-Fi. The password is Suffolk Law. That's it. Very easy. Suffolk Law. No periods, no dashes. We're also very active on the social media. If that is an interest to you, follow us at mass_HPC or tweet at us. The hashtag is #CTH15. Again, very self-explanatory. We are live streaming on the website, mass.gov/HPC. So follow us there. And lunch is going to begin directly at 12:15, but please head back to your seats by 1 p.m. When the program will begin again. Thank you, and I look forward to an enlightening 2 days.
As I thought about these 2 days, and the powerful staff gave me all the direction on what I was supposed to do, nothing is going to give me more pleasure than the ability to introduce the governor. Governor Baker, we've known each other for many years, and it's such a pleasure for me to introduce him. I thought, I've been thinking about the various times I've gotten the opportunity to introduce political leaders, and we have some of the finest here in Massachusetts that know a lot about our healthcare system. But I've never had the opportunity of introducing a high-level official that knows more about our healthcare system than Governor Baker. We go way back to the times that he served for Governor Weld and Governor Solucci, and then the many years at Harvard Pilgrim and working with us at Brandeis at the Heller School. This is a distinct honor, Governor, our Governor, Governor Baker. Thank you so much.
Thank you, Professor. So I'm going to be limping around for the next couple of months because some injuries just never go away. And I just thought it was appropriate that I show up with my crutches and my son's boot from one of his injuries. So I trying to come up with what I might say to all of you. I spent a lot of time with your program for the next 2 days and decided that I would use that as kind of an organizing principle. And first of all, let me thank you for the chance to be here and to speak to you all on what is obviously a hugely important topic for everybody here in the Commonwealth, which is healthcare costs. In Massachusetts, anyway, I think you can all agree that healthcare and healthcare costs and sort of everything about healthcare is kind of a conundrum. We certainly have what most people would call a world-class system, and folks come from all over the world to access our service delivery system here. It's also hugely expensive, but it's hugely expensive on an absolute basis. If you look at the cost of healthcare in Massachusetts as a percent of personal income, we're pretty much right in the middle of where the rest of the country is, which is one of those things that often gets lost in the conversation. It's a major employer at the same time that it's a major cost center. But if you were to ask me what I hear about from employers, and I'd be curious to hear what Rick Lord would say about this, most employers talk more to me about energy costs than they talk about healthcare costs. They talk about housing costs more than they talk about healthcare costs. They talk about regulatory policy and how long it takes to get something done more than they talk about healthcare costs. Now, that could be because of the percent of personal income calculation, which means they just view it as part of the larger issue around total compensation that exists here in the Commonwealth. But it's definitely one of those things where, while it certainly is expensive on an absolute basis, if you look at it in terms of the cost of everything in Massachusetts, it's on the list, but it's definitely not at the top. It's also a huge global cluster for the Commonwealth, and it's one of the things that is part of the Massachusetts and the Boston brand, and one of the most important elements of sort of our position in the global economy, especially when you think about biotech and health IT and big data and a whole series of other initiatives and issues that represent ways in which the healthcare community contributes in a big way to the economic vitality of the region overall. Now, with respect to what to do about that, which is really what you'll all be talking about over the course of the next few days, the first panel's on the benchmark, and that one I find kind of interesting for a bunch of reasons, the biggest of which is the number of variables that you have to factor into calculating the benchmark to come up with some way of feeling that your calculation represents something that's not being driven by forces that are beyond everybody's control. And what I mean by that is, let's take addiction, for example. Addiction is a big issue, especially opioid addiction here in the Commonwealth, and you can't put more than 20 people in a room without running into somebody who's been directly affected by it. And I would argue that one in particular, the healthcare world's had a lot to do with, since 80% of the people who end up addicted to heroin started on prescription pain meds, and the number of prescriptions that have been written for opioids has gone up fivefold over the course of the past 15 years. Now we can debate why that's the case. My own view is my colleagues in the healthcare world have not been as aggressive about understanding the downsides associated with many of these medications as they've been about understanding and appreciating the upside. And that was one of the reasons why we asked the folks at the 4 major medical schools to come in and spend some time with us. And while there's certainly curricula that's been developed for medical school students around pain management and addiction, it's not a core requirement for graduation. And it's pretty clear that a lot of people get through medical school without really ever spending any time at all on pain management or addiction generally. You have to deal with all the issues associated with changes in Medicaid. The biggest one, of course, showed up in your report last year, which was the rolling of somewhere between 350 and 400,000 people into the Mass Health program to deal with the crack up at the connector and the 19% increase in Mass Health spending that came with that. We've been aggressively pursuing a redetermination strategy for all of the folks associated with that process, which I'm sure the Secretary can speak to in more detail than me, both secretaries. But the bottom line is we're pretty much all the way through that. But along the way, that created all kinds of sort of one-time issues associated with your process that created variability that wouldn't have been there otherwise. I also think that, I don't know how you factor demographic information into this. I mean, I'm 58. I'm right in the middle of the baby boom population. The baby boomers are basically 68 to 48. Their role in the healthcare world is going to get increasingly complicated over the course of the next 20 or 30 years. Their parents are, generally speaking, well, somebody said to me the other day that, 60 is the new 50, 70 is the new 60, 80 is the new 70, but 90 is 90, which I thought was an interesting way of thinking about what you all are working through and trying to deal with respect to demographic trends. And then, of course, there are all the issues associated with technology. One of the things that has always been complicated about healthcare is the system's ability to do more things comes with in many cases, a societal benefit that's uncalculable. You can certainly calculate the price associated with the fact the system can do more things, but the ability to calculate what the benefit to society overall associated with that is very hard to do. So I do not envy you with respect to trying to figure out how to create a benchmark over time that can adjust for and control for many of the factors that need to be incorporated into how you make decisions about deciding whether the benchmark, well, there's a hard calculation around whether the benchmark's been hit or not, but then there's a second level calculation around what the elements associated with getting there are, and then what could be done about it, or what might be done about it going forward. With respect to primary care access generally and the overuse of acute care services and institutions, this is an interesting question to me, and I say this as somebody who is a big believer in primary care access and would like to see more of it. I actually think all of the cognitive stuff, primary health care, pediatric services, behavioral health, and mental health, those are all sort of categories and care delivery, components of the care delivery system that tend to get treated differentially, I guess is the way I would put it, by the Medicare program, which for all intents and purposes is the big dog in the system on a payment basis and the one that pretty much determines how everybody else pays for everything. And if Medicare pays a lot less for mental health, behavioral health, and primary care and pediatrics, then it pays for dermatology or radiology or pathology or a whole bunch of other things. Everybody else will too. And that's pretty much been the way the systems work, because everybody calculates everything into a Medicare fee-for-service equivalent, and that's the way people keep score. The problem that creates when you're trying to develop program models that make primary care a bigger piece of the drill and acute care and hospital-based stuff a less significant piece of the drill is you're always playing from behind if the Medicare program just continues to do what it does in terms of how it values what it thinks is important and what it's willing to pay for. And I say that as somebody who, generally speaking, would like to see us do more with the cognitive stuff. But I start from the proposition that it's harder to do that than it should be, because Medicare is just going to keep cranking its own crank on what it thinks the most important components and elements of the healthcare system are. And the place that really affects all of us is in trying to determine within that framework a system that tends to be more heavily weighted toward academic medical centers here than you'd see in other parts of the country anyway. And academic medical centers, for all kinds of reasons, tend to be more heavily weighted towards specialty services to begin with than they are toward primary and cognitive services. And that's a function, again, of not just Medicare, but also federal policy with respect to the way the NIH works, and where research money comes from, and what the feds value. So my point there is that flipping the paradigm or changing the equation with respect to primary care and everything else requires the Commonwealth to somehow climb over or work against trends that are coming from the federal level that have a much bigger influence on anything we can do here in Massachusetts. Now, with respect to payment reform, I mean, it's very clear from reading all the documentation that was put together for this meeting that almost everybody on the payer side believes that they're somewhere between 60 and 80% involved in alternative payment methodologies of one sort or another, and the typical number of their percent of their members that are represented by that is somewhere in the 50 to 70% range, and the provider community, for the most part, had similar kinds of numbers in a lot of their presentations. That's a big piece of the puzzle there. If folks really believe that they're already, for the most part, either serving on the provider side more than 50% of the folks in some sort of alternative payment methodology, or folks on the plan and the payer side think they're already engaged in arrangements where 50 to 70% of the patients are 60 to 80% of the members, or 50 to 70% of the providers they do business with are in alternative payment methodologies, then it's already more than half the traffic and the activity that's involved in there. Now, I don't know how people are calculating the denominator and the numerator on that, but it's pretty clear that a lot of the traffic that's currently taking place in healthcare in Massachusetts is under some form of APM. So what does that tell you? It tells you that while it may be directionally correct, it may or may not be having the kind of influence people would like to have with respect to what actually happens every day on the ground in terms of healthcare delivery, because you still have some of the same issues with respect to primary care and specialty care. You still have some of the same issues with respect to academic medical centers versus community hospitals. You still have a lot of the same issues that people felt moving to APMs might have an impact on. Now, it could be that it's early and that over time the APMs will start to have a more significant impact on some of those issues than they've had so far. But this is clearly, Stuart had a great line one time at a conference I was at where he said, if you're talking about gradualism, where you start to land the plane that's going to land in Boston by starting to lower the altitude in France.
You remember?
I do. It was the greatest line about the gradual approach we take to a lot of things in healthcare. And I wonder sometimes about whether that's part of what's going on with the APM stuff, which is it's important and it's directionally correct, but it's very incremental with respect to its ability to truly change some of the things people care about with respect to the way the system works, because you have other forces that are at work that are pushing the thing in a completely different direction than that. The other thing I would say is that the dual eligible program experiments that are going on, which are in fact not just alternative payment methodologies, but full-blown bundled payments, and not bundled payments in terms of the way Medicare thinks about them, but bundled in terms of putting Medicaid and Medicare together into a single payment for services, and then having people try and treat folks that way. You know, the jury's still out on whether or not that over time, whether that has worked in the short term and whether over time it can work in the long term. And that one, to me anyway, is probably as good an opportunity as any we're going to have to think differently about payment and service delivery with a population that, in my view, if we got this one right, you could have a real win-win where people will get a much better and more proactive approach to care delivery, and at the same time not have the kind of fragmented approach to services that has historically befuddled and bedeviled a lot of people who fell into that category. Now, with respect to network construction and the impact of network construction on healthcare costs overall, I have a fairly simple view on this. I'm actually glad that Norm is sitting right behind me here. Lowell General Hospital has been a low-cost, high-quality provider since I was Undersecretary of Health and Human Services in 1991. Okay? That was 25 years ago. So for 25 years, we've had at least one provider organization that's been a pretty good example of how you can do a terrific job of serving the folks in your community and doing it at a price point that everybody would agree is significantly below the statewide mean. Okay? You owe me $20. Lowell General is not the only care provider in Massachusetts that falls into that category. There's a bunch of others. My point here is whether they were getting paid on a fee-for-service basis or on an APM or under a global cap, that wasn't what made them a low-cost, high-quality player. What made them a low-cost, high-quality player, in my view, was the culture and the approach that they took to what it was they were doing and how they delivered care day after day after day, month after month, year after year after year. And I think sometimes at a high level, we think if we could just tweak this or tweak that, somehow we could move the system. When I look at the data historically, and I think some of the AG's reports on this would bear me out on this, payment, the way people got paid had less to do with whether or not they were a low-cost, high-quality player or a high-cost, high-quality player than just the attitude and the approach they took to what it was they were doing every single day. And there's certainly something to be said for the notion that in some cases, payer mix has some impact on that. But Lowell General's payer mix is, has always been, I think, against the statewide mean, probably, you do at least as much public stuff as, yeah, you're a dish. So I don't think of it, I mean, it's clear to me that it's not the way, it's not who pays them or how much they get paid. It's just the way they go about doing what they do. And I don't think we've ever done as good a job as a Commonwealth as we could do in really understanding why some folks just seem to be better at being low-cost, high-value players than others. Which brings me to the transparency question, which is, I would really like to see us, and I apologize, I've been governor for 9 months, but I've been a little distracted by a whole bunch of other things that have come up along the way. Winter's right around the corner. But I think you can expect to see us get a lot more aggressive about the transparency stuff in 2016. It's always troubled me that if you are a low-cost, high-value, high-quality player in healthcare, there's really no way for anybody to figure that out about you. And And we've got to do, in my view, a much better job of really leaning hard into the whole transparency piece if we ultimately want to be successful. And the other thing I would say about that is it's not just about, there's a whole bunch of different ways I think the transparency piece would matter a lot. I think it would change the dialogue around the acute service piece versus the primary care piece too, if we did a better job with transparency. Because some of the differentials there are staggering, and most people would never believe them until they actually saw them. But since most of the people who know about them tend to be people who spend a lot of time swimming around in healthcare data and not really much of anybody else, I think that's a problem that we have got. And I'll take some of the hit for that. We've got to do a better job of making that available to people. And the final panel you folks have put together is the one that sort of talks about what next, and that in some ways may be the most important one of all. But I'll give you my 2 cents on this. And the way I thought about this was a little different maybe than the way you thought about it, which is I said, with respect to patients, what do I think our great challenge is? And I think our great challenge with patients is we have a system that's built for the 95% of the population that gets sick once in a while, but for the most part is reasonably healthy. It's not built for the 5% that's very sick and very complicated. And you can call it an 80-20 game or a 95-5 game. I don't much care. The numbers sort of work for either population breakdown. But the bottom line is the system's organized still now, today, for the most part, as a transactional system that's designed to serve the folks who are relatively healthy and have an occasional interaction with it. It's not designed to serve the people who are managing 2, 3, 4, 5 comorbidities, who are very sick and dealing with all kinds of, who are ambulatory for the most part and dealing with all kinds of significant circumstances and complications. And the fact that we haven't really figured out what a strategy is to support caregivers, and I mean when I say caregivers here, I mean both the professional caregivers, but also the non-professional voluntary caregivers, family members, neighbors, brothers and sisters, moms and dads, sons and daughters. The fact that we really haven't figured out how to incorporate them into the way we think about care delivery generally for the 20% that's really sick and needs a different kind of way of thinking about this is kind of indicative to me that we have a long way to go there. And on the patient stuff, I can tell you that one of the things I'm going to want us focusing on is how do we do a better job for the 20%, the 5% that really do represent the folks who are truly managing everyday complexities in their own physical and mental health, and stop and not think the whole thing needs to be designed around the folks who are relatively healthy and have an occasional opportunity to engage with the healthcare system. On the clinician side, this is a problem that I don't have a solution for yet, but I've been thinking about it a lot, which is probably troubling, because if I've been thinking about it a lot, I should have come up with an answer. But at exactly the time when I think we would benefit from being a little more general in our knowledge and understanding and a little more team-based in the way we went about care delivery, we seem to be getting more and more specialized and more isolated in terms of how we think about healthcare on the clinician side. And if you were to say to me, in addition to the fact that I don't think anybody should be able to graduate from medical school without taking at least one course that creates a core competency in pain management addiction, the other thing would be in team-based approaches to care delivery and a recognition and understanding that for the 20%, the 5%, they're really sick, the only game that's going to work for those people is going to be a team-based approach to care delivery on the clinician side. The system isn't organized really to do that. It's not financed to do that. And we have a long way. And this is one where I do believe, if we are directionally heading in the right direction for this, I think we're probably a little bit past France, but we have a hell of a long way to go to get to Massachusetts. But this is one where if we really want to do something for patients, especially those who are dealing with multiple conditions and circumstances, we've got to figure out a way to educate clinicians and support clinicians around team-based approaches to care delivery at a point in time when I feel like we're heading in the opposite direction and just getting more and more specialized in the way we think about care delivery and medical education and everything else. I get the fact the system's more complicated. It's more technically sophisticated than it used to be, but there has to be a recognition and understanding that team-based approaches, especially to complex patients, is really a much more effective way to serve and take care of them. On the hospital side, there's going to be an ongoing struggle around inpatient and outpatient services and care delivery that's going to be driven by a lot of things. It's going to be driven by technology. It's going to be driven by patient choice. It's going to be driven by payment systems. It's going to be driven by a bunch of different things. And for a place like Massachusetts, which has such a big installed base on the inpatient side, I'm not exactly sure what that means. But it could be extremely disruptive and not necessarily a bad thing. On the other piece about this is most of our ambulatory care providers, whether you're talking about urgent care providers, emergency service providers, primary care providers, mental health providers, even community health centers, in Massachusetts, they're almost all hospital connected or hospital driven. In most other parts of the country, they're not. They're typically freestanding. And if you look at the Mayo Clinic, for example, the Mayo Clinic is basically a big physician, multi-specialty group practice. And unless you're really deep into healthcare, you don't even know the name of the hospital that they work with. St. Mary's, okay? Now, the reason people don't know that is because the system is organized around the group practices and around the ambulatory system. It's not organized around the inpatient hospital facility system. In Massachusetts, the system is much more organized around the hospital piece, not so much around the ambulatory piece. And I don't know how to change that. I'm not sure we should change it, but I'm telling you that as some of these other issues play out over time, it's going to create a very significant issue for everybody who's part of the care delivery side of the equation. On the two other things I just want to mention quickly, one is pharmaceuticals and the other is technology. On the pharmaceutical piece, I guess what I would say is that I think I have a hard time seeing past the opioid piece these days because it's been such a big part of our focus. But with respect to that one, I do believe we, as a Commonwealth, and probably as a country, have not been as judicious in the way we've gone about prescribing those medications as perhaps we should be. And it makes me wonder how we've been with respect to lots of other medications as well. I get the fact that the debate most of the time is about the price point of drugs, but the other piece that's, in my view, equally important when it comes to drugs is the prescribing of drugs and how we choose to use them. And on that one, while I certainly think there's a debate to be had and should be had around the price point, especially with regard to certain medications that seem to magically change their price point, I think there's another question associated with sort of the way we as a community prescribe and access them. And on the technology piece, I think that there's really good news in the technology space. I mean, I'm a big believer in automated medical records and clinical practice supports and all the rest. And that train seems to have left the station and is moving at a pretty high rate of speed. And I think has the potential to significantly enhance and improve the quality of healthcare and help us come up with smarter and better ways to do team-based approaches to complex populations, as long as some of the process barriers can get broken down, and to bring a very different and more substantial approach to supporting clinicians and, frankly, patients over time with respect to the way they perform. But the flip side of that one is we are going to have a lot more information that's digitally available, which I'm sure is going to create some concerns for many people around some of the HIPAA issues associated with privacy. And I do think this is something I would like you guys to think about, which is how can we make sure we get the most mileage out of big data and out of all the information that used to be in paper records that's now going to be digitized and organized in a way where on a de-identified basis, it could provide a lot of guidance and a lot of support to people both on the practice side but also on the patient side with respect to what the best way to deal with certain kinds of illnesses and conditions would be. I mean, I think it has tremendous potential to be a big positive, but if we don't deal with some of the rules around process and access and all the rest, it may not ever amount to what it probably should be. And then the final thing I'll say, and then I'll be happy to take questions if you have time. The demographic trend combined with the technology trend is not something that can be ignored. We are getting older as a society, and Massachusetts in particular is getting older. And with that will come all kinds of interesting challenges on the healthcare front that are just sort of driven by that and undeniable. Combine that with the technology and the ability of the system to do more and more things for people, and it will create some real challenges with respect to our ability to hit the benchmarks. And the final thing I'll say is that I would really like to know and understand more about why the Lowell Generals of the world have continued year after year after year to be very strong players on the quality side of things, and really strong players on the cost side, but haven't become kind of the center of the way we think about healthcare and talk about it. I mean, almost all of the strong players in that space don't really get a heck of a lot of time or attention, and I absolutely believe there's something to be learned from what it is they've been doing. And again, I appreciate the chance to speak before you and look forward to working with you going forward. Thank you.
Would any of the commissioners like to? Yes, Dr. Hattis.
Governor, thank you for your comments. You've talked about a lot of different areas, but let me focus my question on the issue related to Lowell General, because it's sort of an issue that I feel like I've been a broken record about since I became a commissioner, which is both about the culture, but in a metric sense, we don't know very much about, for our providers, especially our hospital providers, what it costs them to deliver a service, a gallbladder surgery, an outpatient endoscopy, whatever. So my hope is, especially with you and the administration's interest in transparency in 2016, that some of the energy can go into focusing on us understanding that better. I mean, I know there's some research going on at the University of Utah to try to, get at issues like this, but I think unless we could get that kind of information and compare, we're sort of always left wondering that if when providers want more on the revenue side, whether or not it's happening because they really have the need or it's an efficiency issue. So,
yeah, I agree with that. I think one of the amount of work that's been done in what might be called activity-based costing in healthcare is pretty minimal compared to what you see in a lot of other spaces. Most of our cost work has been done around revenue-based costing, which is a slightly different model for all the reasons you expect.
One quick comment, though. You did say at the beginning how you talk to employers and they don't tend to bring up healthcare issues. The thing I want to say is, when I talk to my GBIO colleagues who are often the employees, when they see their deductibles going from $500 to $1,000 to $2,000, or their kid who needs outpatient mental health and the provider doesn't take any insurance and they're all paying out of pocket, they talk to me a lot about the burden of healthcare costs.
Absolutely right. Yep, absolutely right.
We'll take one more question. Yes.
And Governor, you asked me what we're hearing from our members as well about the cost of healthcare. And we did an extensive survey last year, and healthcare costs are among the top four, but didn't predominate like it has in past years. But I would offer two observations. One, premium growth has moderated in the last few years. So unlike the 5 or 6 or 7 years ago when employers were getting double-digit increases and our phones were ringing off the hook, we haven't experienced that recently. But my other observation is in certain industries, and particularly manufacturing, and 30% of our members are engaged in manufacturing where costs really do matter, and they participate in the global environment, it's still a really important issue for them. So just wanted to share those observations with you as well.
Yep, agree. Thanks.
Thank you, Governor. I was interested in your comments on alternative payment mechanisms and the penetration rate. And you rightfully said the denominator is confusing at times. Most of the data that we've seen is that 50% penetration rate is primarily in the HMO population. And obviously with Medicare's strong push, very aggressive and ambitious goal in the next several years to get that number for Medicare patients up to 50%, we may have quite a ways to go. Do you have any thoughts or suggestions to the Commission as to what we can do to try to move that number up, that enrollment and participation on both the patient and the clinician side, to something that can give us much better results than we've had to date?
Results in terms of the rate of participation in that type of a model, or results
Exactly.
in, yeah, okay.
Exactly. In that when it works effectively, we do get less expensive but still high quality health care.
I think the biggest way you could move the needle on some of this is to highlight where it's been successful, and to do it a lot. I mean, one of the things I've certainly learned in my my time in public life is you have to say something over and over and over and over again before it actually penetrates. And I think on the alternative payment methodologies, if Medicare moves in a significant way in that space,
No problem.
they are kind of the chassis that everybody keeps score on, so that makes a huge difference. But a lot of what Medicare does also preserves some of the stuff that people express concerns about with respect to the facility-based and the technology-driven approach to reimbursement, which has kind of dominated our market and the healthcare sector overall for as long as I can remember. So if Medicare were to truly move in a big way in that direction, that all by itself would move a lot of other people along with it. Because everybody does keep score based on what Medicare does, for better or for worse.
I'm so appreciative of your time, Governor, and of course, you didn't let me down. You hit all the points that we need to focus on, and I'm looking forward to the rest of the conference, and we will let you know if we find some nuggets.
We're looking forward to the rest of the conference, too. You've got a lot of terrific players coming to spend time with
So
you.
thank you so much for joining us. It's really been a pleasure.
Thank you.
Thank you, Governor. And just as a program note, unfortunately, the Senate President will not be joining us today. He is expected tomorrow, but we will be moving on in our agenda today. I think the Governor highlighted an interesting way of framing up this 2 days, which is the two levels of analysis. And the first level of analysis is how did we do against the benchmark? And this is a methodology that is undertaken and published by our sister agency, the Center for Health Information and Analysis, which we'll talk about in a second. But he also talked about this secondary level of analysis. And to me, this is really the role of the Health Policy Commission, which is to say, why and what do we do about it? And what do we think about some of these trends? And that policy debate is, of course, grounded in data and evidence, but requires nuance in how we think about how best to interpret the results of CHIA and to move forward. And that is really one of the main goals of these two-day hearings, is to inform that secondary level of analysis. But first, we start with the first level. And so I'm delighted to call forth Aaron Boros, who is the Executive Director of the Center for Health Information and Analysis, our sister agency established under Chapter 224, to discuss and to present to the Commission on the state's performance against the healthcare cost growth benchmark in 2013 and 2014. And for those of you who are interested, there is more background information on what the benchmark is, how it is calculated in your program books. But Aaron, please join us at the panel.
Good morning. Thank you for having me here today. Until about 3 or 4 weeks ago, I really thought that our relationship between CHIA and HPC was strong, and then David put me to follow the governor. So I'm worried that he's trying to say something. Obviously, very difficult to follow somebody with the kind of leadership and expertise that I'm following today. And fortunately, my remarks will I think really put some numbers and some statistics behind the points that the governor was trying to make, and so I think you'll see some natural connections. CHIA, of course, is the agency of record for many of the healthcare statistics that provide the foundation for the work that will be happening over the next 2 days. Our annual report that we published in September covers the cost of healthcare in Massachusetts, statewide quality indicators, and metrics of changes in the healthcare market and performance in the healthcare market. And are you going to help me with the slides here? Great. CHIA reports on a variety of other statistics as well. In the next couple of months, you'll see we'll be updating our access measures, which relate to our household survey and other information about access, as well as information about utilization. For instance, our hospital profiles will be updated later this year as well. So, of course, the headline statistic from our annual report is the 4.8% increase in per capita total healthcare expenditure growth. That's faster than the 3.6 benchmark set by the Health Policy Commission. And as a reminder, that 3.6% benchmark is intended to track potential gross state product. So a long-term economic growth statistic. And so to the extent that we're exceeding that long-term growth statistic, particularly in years where economic growth is somewhat slower, we will have an increasing share of our economy devoted to healthcare. So in order to know what sense to make of this number, you have to understand what's driving it. This year we found, and I've spoken to you before about this, we found that Mass Health is a big part of that story, with especially enrollment changes, but other changes in the program largely associated with the implementation of the Affordable Care Act that created a lot of volatility in Mass Health and other subsidized programs. Looking at the commercial side of the market, membership in the commercial market was essentially unchanged over this period of time, and per member growth growing at about 2.9%, so under the benchmark for the commercial market solely. As the governor mentioned, prescription drugs has been a strong focus of attention, not just for the experience of the healthcare system, but on the cost side as well. That sector of the commercial market grew at 12%, far faster than other sectors of the commercial market, other sort of service categories in this commercial market. But of course, prescription drugs take up less than 20% of overall spend. If you look at 75% of the spend, it goes to hospitals and doctors. And so what you see in the commercial market for hospitals and doctors is that spending was increasing less than 0.5% from year over year. And given inflation being faster than that, even in the 2013 to 2014 period, that's an interesting indicator of where we're headed. All of these figures are preliminary statewide figures, and we will be updating them 18 months after the close of the calendar year with final figures. That largely reflects the penetration of alternative payments in Massachusetts, because there's a lot of reconciliation that happens over the course of the year. Because these are preliminary figures, we've de-emphasized this year the performance of individual providers and plans, although we have shared that information with the Commission to inform your policymaking and planning. In order to give some context for healthcare cost growth, we, in our annual report, look at quality measurement as well. By and large, Massachusetts quality measurement is consistent with national averages around the various measures. But this really, speaking of the 20% and 5% that the governor was highlighting, this is an area where it's very difficult to talk about quality performance of the Commonwealth. Not only is it the performance of the healthcare system relative to those patients who are most engaged in the healthcare system necessary to understand, and it's very difficult to tease that out separately. But also you, of course, have wide variation between providers in Massachusetts, and so overall performance may be misleading. Although I will say that even within any individual provider, we see variation in performance in different domains of care. The 5 up on your screen reflects work that the Statewide Quality Advisory Commission has been doing recently to help provide a framework for quality measurement and improvement in Massachusetts. We've just in September met to discuss these 5 areas. I, of course, don't have as much time as I'd like to talk about all of them, but I will highlight one of them is opioid use and starting to bring the quality measure paradigm to improving the performance of the Massachusetts healthcare system with respect to substance use, both on the pain management side and on the addiction treatment side. And so that's one of 5 areas. Others will sound familiar to you: integration of behavioral health and interest of the commission, appropriateness of medical care, including readmission, something that CHIA has done a lot of work, as well as many other players in the Massachusetts market, looking at end-of-life care, and then finally maternity care. All areas that we think that 2 things are possible. One is providing a better framework across the state for organizing or at least talking about disparate efforts, and then also emphasizing areas where we think improvement and sustained improvement is possible. Switching to some metrics of the performance of the market and the changes that are going on in the market. The commercial market evidence is 38% of members under management by a alternative payment contract. This is somewhat lower than the figure that the governor was using, and that's because the governor was looking at the whole market. This is just the commercial market, and we actually see that Medicare is pushing this number higher. So in this area, Medicare is a real leader, and to the extent that Medicare, as he referenced, is an anchor for how the health system is administered, their leadership in alternative payment methods is a positive sign, and maybe goes a little bit to Ms. Everett's question earlier about how we can move forward. So Medicare, and this is work that the Health Policy Commission reported on in January, is at numbers between 40 and 60%, depending on which Medicare population you're looking at, while the commercial market in Massachusetts is at a little under 40%. The Medicaid program in Massachusetts is trailing behind that somewhat, especially with respect to global budgets. Finally, and again, this is the whirlwind tour of the performance of the Massachusetts healthcare system, but the governor, Mr. Lord, and Dr. Hattis had this interesting conversation about employers and patients and sort of their interaction with the healthcare system. And there's a really interesting story there. One is that premiums, as Mr. Lord said, have really moderated, and we have over several year periods seen that, and that is important to employers. On the other hand, we see that cost sharing is increasing faster than premiums, and cost sharing increased 5% year over year in 2014. And the 1 in 5 number on the screen reflects the fact that we have, for the first time, about 20% of members enrolled in high deductible health plans. It's more than half of members in the individual market, but that trend is increasing in every group size, where we have higher and higher deductibles that patients are responsible for. And that certainly is consistent with the 5% growth in cost sharing across the market. So I could certainly speak for another hour or 2 on these metrics. I will instead defer to some of the people that you have today on panels and as expert presentations. But I am happy to take your questions, and I look forward to engaging in the rest of the hearings over the next 2 days.
Well, thank you so much, Aaron. Let me just ask you one question. When we've been talking, I know we've been talking to you a fair amount since your report came out with respect to the 4.8 exceeding the benchmark. In your report and subsequent to that, you have emphasized the fact that much of this growth was the result of a larger than anticipated growth in mass health, in part, as the governor pointed out, due to the problems with the connector, but also in terms of the mix. So but you said you were going to go back and look more deeply at that 4.8. Having done that, do you have any change in your initial perception, or is it still holding true that when you look beyond that, we really did come in under the benchmark?
I'm not sure about your last
So
statement.
the question is, other than the larger than anticipated growth in mass health, if you were to look at the health and cost aspects of the rest of our system, how would you characterize it?
So the enrollment growth in mass health is, I would say, it presents something of a mystery, because we have increased enrollment in mass health, but it's not clear where those people were previously insured or uninsured, and we don't have good data sources to understand that. So but if you accept that at face value, that we have insured more people in Massachusetts through the Mass Health program, then it's an indication that the increase, the benchmark statistic, the 4.8%, is reflective of actually increasing coverage as opposed to an increasing per member cost. That said, I don't change the number that's on the screen, right? That is a real number that is really faster than economic growth, and that reflects real spending in both the commercial market and the public programs. And so, with respect to overall spending, with respect to the crowding out of other kinds of investments, I think that that's a number that has to be taken seriously. And the questions you're raising, I think, are really important to inform what you do about it. But as an indicator of the market performance, we're absolutely solid on that. I also mentioned that these are preliminary numbers. We did find from prior years these headline statistics tend not to change very much. So we have a high level of confidence that that even when we finalize these numbers a year from now, we will still exceed the benchmark.
David?
Aaron and Mr. Chairman, and this may be as much for David Seltz. You had done and we had done a little bit of looking into how spending increases in Massachusetts compared to the rest of the country. And I know, Mr. Chairman, that you've brought that up before. So I wonder if you could talk for a minute about that, either David or Aaron. And obviously the pharmaceutical growth was very rapid. And how does that compare if you take out the pharmaceutical component versus the hospital, physician, outpatient component, so we can get a sense of what that looks like?
Commissioner, as you note, Massachusetts is not an island, and as our chair often says, it's important to see us against the nation. I will preview that we have some slides upcoming before the first panel that will provide some data points that answer your very specific question. So look forward to that. Thank you for the promotion.
And what about the second one, Aaron? Do you want to focus on if you took out the
Pharmaceutical.
So that's precisely what I was trying to do with the statistic around the hospital and physician growth being very modest over the course of the year. I don't have statistics for other states and the national trends around that area. Even the Medicare statistics that are published for that period are their projections for 2014. We're look forward to working with the commission to better understand that.
Yeah, we do want to, as you pointed out correctly, the 4.8 is the 4.8, and we appreciate your doing that. But our job is to sort of look underneath and say, okay, what's really happening? You know, should we be very concerned about our overall delivery system, our hospitals and payers, you know, not adhering to the spirit, if not the letter of the law, in terms of their growth? And I think we come away with the idea that our healthcare system, at least for this year, I'm not saying anything for future years, has kept the growth in line with what we expected. And therefore, when we look at what we should do, we need to bear that in mind. So that's the reason why I raised the issue. I think that one could be misled by the 4.8, not that we want to ignore it. And again, you know, if there were reason, you know, I'm not at all suggesting that we need not be concerned about the growth in our healthcare spending. I, of all people, would never say that. never. But I do want to acknowledge the good work that's being done by our physicians and our hospitals and our health plans. So, I think it's a mixed bag, and I think this issue about prescription drug spending is something that we do want to look at hard. Other questions or comments? Yep, Madam Secretary.
Good morning, Mr. Chairman. I just want to underscore something you said of the 4.8%, because if you peel back the onion of the 4.8% around pharmacy and around what happened in Mass Health when the connector failed and more than 350,000 people were put on temporary AA. So while there was a 19% growth or 23% growth in the Mass Health population, that's reflected in this number, if I recall correctly, it's a 19% increase in spend. So I do think it's important that we, and actually one of my questions, which I'll forecast it to many in the room, is that we continue to see, however, about a 3 to 4% growth every year in the Mass Health enrollment. And given the state's sort of generally flat population, the high rate of insurance coverage in the Commonwealth of Massachusetts, I'll be asking questions around where we think this trend is continuing. And basically, we've seen a decrease in unemployment. So it's just sort of if Mass Health is continuing to experience annually 3.4, 3.3, aside from the two, what I would call outlier years of FY14 and 15, it'll be interesting to see where these trends are in terms of the commercial and other populations. But I just want to echo that.
Okay, one last, Ron.
An interesting point to consider would be if you look at some of the data nationally in terms of projections, and from a commercial insurance perspective, pre-retirement, overall, most of the experts in the country are looking at approximately a 6% annual increase. And that would be consistent for both premiums as well as out-of-pocket expenses. In retirement, we're looking at also, according to the Office of the Actuary, into the foreseeable future, approximately a 6% increase in premiums, although out-of-pockets will be approximately 3 to 3.5%. So those are the numbers we're looking at. Although the numbers have been good from my perspective, when we look at even that 4.8%, the question becomes, mentioned employers not having an issue today. Will they have an issue over the next couple of years if the projections are accurate and costs do increase?
One thing that CHIA is careful not to do is project the future, right? So and this goes to the distinction David made at the beginning, is that we are doing our best to describe the system as best we can in a timely fashion to allow for policymaking and decision making. It's clear that if costs nationally or in the state grow faster than the economy, and it just increases that pressure on everybody. There's really interesting questions about who bears the burden of that cost shift or that cost growth, and not just between patients and employers, but also between insurers, providers, the government, and the private sector. There's lots of interesting pressure that will be put on, but I take a pass when I'm asked to sort of what does the future hold.
Aaron, thanks so much. And the Commission is not only grateful for the work that CHIA has done, particularly to prepare us for these cost trend hearings, but also in anticipation of your revisions and further explications for our cost trends report to be published in December. So thank you again.
Thank you. It's been a pleasure working with the Commission.
Good morning. I'm Wendy Everett, and I'm really delighted to have the opportunity this morning to introduce Dr. Amitabh Chandra. Dr. Chandra is the perfect speaker for us today because he has the background to really introduce the important topics that we're going to be dealing with in the cost trends hearing today. As director of the Health Policy Research Program at the Kennedy School of Government, he's an expert in both cost trends and innovation. You each have his CV in your packets, but he's written about topics that are very relevant to all of the issues that we're going to deal with today. Medicare's spending on post-acute care, which you'll all remember was a very critical topic for us last year and continues over to this hearing. He's written about mass health reform and emergency department utilization, another area where we're really interested in how we can drive down costs, on how to improve primary care as another cost reduction. He's taught at Dartmouth, at MIT, and now at Harvard. And he's an advisor to the Congressional Budget Office, and on occasion has also been an advisor to the Health Policy Commission. I was really impressed in reading his CV with his 19 very prestigious awards. As a young scientist, particularly the fact that he won the Best Economist Award for people under 40. This is really depressing to most of us on the commission. So it's not only daunting, but it also may explain why he has 4,208 followers on his Twitter account. And where you can read his opinions not only on the Cadillac tax and health policy, but also on Pakistani food and bourbon. David Cutler is an avid follower of his tweets, and my guess is that if you have a question for him afterwards, you can get his Twitter account. Welcome, Dr. Chandra. We're really thrilled to have you here today.
Thank you, Commissioner Everett. And let me just do a little bit of expectations realignment before I get started. You should know that this morning when I taught, I mostly used slides and information from CHIA and the Health Policy Commission. So here I am. Thank you for inviting me. Thank you and your terrific staff for the incredible work that you have all done so quickly. Massachusetts has always been the crucible of innovation in healthcare, not only in devices and in biopharma, but also in health policy. And while it's true that the governor encouraged us a few minutes ago to think about doing the kinds of things that have been shown to work in other places, what's interesting is that all the other places are looking to us to tell them what to do. So my own thinking on this is we have to innovate, and that's the theme of this morning's conversation. So let me put all of this into perspective for you. What I have on this slide is a graph that only economists would appreciate, but I thought, why not just go for it? So what this has in red is the long-term growth rate of healthcare spending in the United States. And what you can see is that starting around the year 2000, what we started to see was a slowdown in that long-term spending rate. What you see in blue is the growth rate of GDP. And what I did was I took the growth rate of GDP and just added 2.4% to it. And you might say, well, why on earth would you want to add 2.4% to the growth rate of GDP? I did that only to make the point that when you add 2.4% to the growth rate of GDP, the two series they sort of track each other. They're mostly in line with each other. So over the past 40 years, healthcare spending in the United States has grown at the growth rate of GDP plus 2.4%. Now, why this is it's exciting, this is worrisome, what you're starting to see is GDP is starting to pick up. And as GDP picks up, many of us believe that healthcare spending will start to pick up as well. I am one of those people who believes that the Affordable Care Act has just about every idea that we know of in it. But the ACA is not really able to take full credit for that slowdown, in part because that slowdown started at a time when President Obama was the junior senator from Illinois. So clearly something else is responsible for that slowdown. And my sense is that while policy has some role to play, the largest reason for that slowdown was probably a slowdown in innovation. And that's going to be the topic of this morning's talk. So when I think about innovation in healthcare, like many of you, I think about products like this. This is a tripla, which is 3 antiretrovirals for HIV rolled into one daily cocktail. Something like robotic surgery, which has growing evidence that it works in some conditions. We don't know about all the other conditions. We've got Sovaldi for hepatitis C, which I'll spend a lot of time talking about. But then we've also got innovation outside devices and drugs. So this is a picture of Connie Culp, who is the first recipient of a face transplant at the Cleveland Clinic. She was shot in the face by her husband as part of a failed murder-suicide back in 2004. But as a result of the spectacular work that was done at the Cleveland Clinic, she can talk, smile, smell, and taste food again. So this is all innovation, and this will all drive up healthcare premiums. This is the kind of innovation that is often in the news. It's exciting, it's expensive, at times it's valuable, but from time to time it's not that valuable. And our challenge is how to pay for the kinds of innovations that work while resisting the pressure to assume that simply because something is new, it's better than existing treatments. So let me illustrate this challenge. And this is an old example that I love to talk about because I think this is just a terrific metaphor for the challenge. This is proton beam therapy, and we have one of these centers here in Boston. So this is to just build the device itself. You need to build a cyclotron the size of a football field. The fixed costs of building it are somewhere between 120 million to 150 million. So this is just to build the technology, not to treat anyone. It gets used for children with pediatric brain cancers, where there's some evidence that the treatment may actually be valuable. But it mostly gets used for men with prostate cancer because there are more men with prostate cancer than children with brain cancer. For prostate cancer, we actually pay quite handsomely for this technology. So if you look at Medicare, Medicare pays something like $32,000 to treat a man for this technology that is completely unproven. We don't know the benefit of this treatment for prostate cancer. We do know the cost, and we're using a lot of this technology. I call this technology and I'm not trying to be facetious, but I think this is really, there's some seriousness to this, the Death Star of all medical technologies, because nothing so big and perhaps so useless has ever been invented before. But this highlights a struggle that we face in American healthcare every day. I think plans in Massachusetts and plans nationally would love to turn the lights off on this technology for prostate cancer, but they're unable to. And the reason that they're unable to is because they're often operating in the shadow of Medicare. And when Medicare covers these technologies without regard to value, with sort of an infinite willingness to pay for new innovations of this type, it becomes very hard for plans in states or even the Medicare Advantage plans to start to say no to treatments like this. So it's another way of highlighting the challenge that David Cutler raised a few minutes ago, that there are many things we can do about innovation, but there are certain forms of innovation where we're really bargaining in the shadow of Medicare. And if we're bargaining in the shadow of Medicare, there's only so much that we can do as a plan or even as a state. Now, unfortunately for us, these proton therapies have really taken off. So not only is, as I've said many times, unproven for prostate cancer treatments, the number of these centers that is opening up over time causes me great anxiety, because in some sense what it's telling me is if you view this technology as a crystal ball into whether or not we're going to manage technology growth from affecting spending growth in the future, is I look at this and think, no, that spending growth is going to come right back, because here's something that doesn't work and we're not able to say no to it. Imagine saying no to all the things that actually do have some positive benefit. So let me move along and kind of move a little bit away from devices and talk about something that's on everyone's mind, which is the growth of specialty drugs. So these are an example of, this is just the annual cost of new oncology drugs approved by the FDA in 2012. And this comes from an article in Health Affairs, and you can see that the average cost is about $100,000, right? So these are new oncology drugs. So this is where there's actually some evidence. This is not like proton. The biopharma industry, for all its problems, ultimately is regulated. It has to do 3 clinical trials, and that's not always true of the rest of the industry. What you see over here is extraordinarily expensive drugs. If we assume that the incidence of cancer is 5 in 1,000, and let's just assume, just for the sake of doing math, that 1 in those 5 patients are going to need access to one of those drugs, premiums would have just increased by $100, just for oncology alone. Now, if we think that one of those patients may need 5 drugs, then premiums would have gone up by $1,000 alone. And so the point here that I'm making a number of different points, but one of the points that I'm making is the kinds of innovations that are responsible for cost growth may be very different than the kinds of innovations that are actually responsible for the level of spending. My own sense is that innovation in biopharma is probably really responsible for a large part of spending growth, but is actually not a big part of the level of spending. And what we want to be thinking about as we reform healthcare in Massachusetts is not only the growth rate of spending, because if we only focus on the growth rate of spending, we tend to focus on products like this. We also want to think hard about the tremendous opportunities that lie in reforming the delivery system, because that kind of spending contributes a lot to our growth. Now, these kinds of facts are likely to get a little bit worse in the coming years. So this is a chart from Peter Bach at Memorial Sloan. And what Peter's done for us is shown us the median cost of cancer drugs at the time of FDA approval. And he's taken a very long time horizon from 1965 to 2014. And you can see that orange line go upwards. And you might look at that graph and say, well, that's a linear increase. It's actually not a linear increase, because Peter, being a very, very smart person, he put everything on a log scale. And so what that does is it sort of understates, the ocular analysis of that graph really understates the extent to which prices in oncology have gone up. A 1-inch increase in the cost of a drug is really a 100-fold increase on that graph, right? So we're seeing exponential growth in the cost of oncology drugs. This is likely to be a bigger trend in the years to come. Why? For several reasons. The first is the ACA has expanded market size. So 10% of Americans will now have access to health insurance. This is unambiguously a very, very good thing. The problem with it, though, is that market size is something that manufacturers pay a lot of attention to. And the best research in economics suggests that a 10% increase in market size results in a 40% increase in the availability of new molecular entities 20 years after the increase in market size. So the ACA alone, if I can extrapolate, the ACA alone 20 years from now will create sort of innovation in new entities that serve the population that the ACA expands market size on. So that's kind of one reason why innovation will increase and give us a lot of trouble with our targets. The second reason is Medicaid rebates. Now, Medicaid rebates are completely well-intentioned, but one of the things that Medicaid rebates do is they increase commercial prices. Because if I'm a manufacturer, what a Medicaid rebate is telling me to do is to think about the best price that I should charge a commercial plan. And if Medicaid is willing to pay 85% or 80% of what a commercial plan will pay, I'm going to increase the price that I charge commercial plans. And the best evidence there suggests that a 10% increase in Medicaid will increase commercial prices by 10%. So this is a way of saying that there are these spillovers from one program, however important and however well-intentioned, on the rest of the system. Third, one of the most valuable reforms in the Affordable Care Act is the fact that it actually increases the value of insurance. The ACA removes annual limits on what an insurer will pay a family, and that's a terrific thing. It removes lifetime limits as well. But in doing so, what it's doing is it's providing valuable financial protection where patients need it more. But as part of that, it's also sending a signal on market size to manufacturers saying, if you innovate in this tail, we will now pay for those innovations. And so unsurprisingly, I think these three forces will mean that we will see an even larger wave of innovation in the years to come. I think this will be compounded by the arrival of personalized medicine. Personalized medicine will increase prices for two reasons. The first reason is that many of these therapies are targeted, so they're likely to work in the patients who have the right targets. But as a result of that, manufacturers will charge higher prices just because the therapy works more. Many cancers will get the designation of orphan status, which means that they will get 7 additional years of exclusivity, which means that prices will go up as a result of that exclusivity. And finally, the 21st Century Cures Act will probably increase innovation only because it makes it easier for the FDA to approve new drugs on the basis of surrogate endpoints. So all of this is very exciting, but all of this is very, very bad news for a state that is trying very hard to manage cost targets, because again, all of this is happening at a level that's much bigger than our state. We might ask, well, since it's happening at a bigger level than our state, what are other players and what is the country really doing? I think what we're doing as a nation is we're unprepared for a lot of the difficult choices that lie ahead, and we're mostly playing hot potato. So this is sort of how it works, I think, nationally. The payers have historically made economic decisions in specialty drugs. They hate being in the sunshine. So what they've been trying to do is push the risk down to patients in the form of high-deductible health plans. The problem with high-deductible health plans is they don't affect high-cost patients, so unsurprisingly, they don't save a lot of money, and they certainly create a lot of confusion for low-cost patients. So that's really not the winning strategy to save money, and so unsurprisingly, it doesn't save money, so what do we do instead? Well, instead what we do is we try to push the risk down to providers. Now, most providers, even Massachusetts providers, lack the training, the data, and the comfort to make these cost-effectiveness decisions. And so, unsurprisingly, pushing the risk down to providers, while it makes payers giddy, is probably not going to pay off in the short run. So then what we do is we pass the buck on to policymakers, and that would be people like yourselves and myself. And the problem with the policymakers, is that we're not that different than the payers. We like to push for broader and broader bundles because we also like to be out of the sunshine. But the broader bundle that we push for, the broader that bundle, the more we're insulated from the hard trade-offs ahead. And so, I don't know what the next iteration of the hot potato would be, but one of the things that I would caution you to be very skeptical about is to be very skeptical around snake oils that will be sold to us around the possibility that a bigger investment in wellness will save us money, or a bigger investment in consumer-driven transparency will save us money, or that a bigger investment in population health will save us money. I think all of these things may save us money, but there's really no substitute to paying less or doing less.
That's just right. Thank you.
So let me just give you my takeaways at this point before I start to turn my attention to opportunities. Innovation responds to market size, and I think the signals for market size to manufacturers are unambiguous at this point. We're telling manufacturers to innovate more, which is good. They will innovate more. What is bad is that, I don't think we've figured out exactly how much to pay on healthcare and how we're going to pay for it in the social insurance programs. A lot of this innovation is happening because of market size incentives that are much bigger than those that come from Massachusetts. And so it's unlikely that we as a state can actually affect innovation in treatments or in devices. But I think what we can do is lead on every other form of reform. So let me think about and share with you some ideas on what we can do there. I think the single biggest thing that we can do as a state is to stay laser-focused on the opportunity for thinking about competition in healthcare markets. And let me tell you a little bit more about competition. So the world's leading expert on market competition in healthcare is Limor Daphne at Northwestern, and she's going to come and talk to you tomorrow. So let me just spend a little bit of time talking about competition and encourage you to press her on all the details. But I think what you want to do is you want to be very careful about facts like this. So if you look at mergers and acquisitions in the hospital industry, the blue bars do not bode well for patients and their premiums. The numbers of hospitals that have been involved in M&A transactions over time has been increasing like a straight line. The number of independent hospitals has been falling like a straight line. Economists who have studied this question will tell us that not only does consolidation result in an increase in price, it often results in a decrease in quality. So it's not as simple as saying, well, we got higher price, but maybe we got higher quality. It looks like this is a total money and quality loser for citizens of Massachusetts. So this is something where you have shown great courage, and I encourage you to continue to show that courage going forward, because I don't think the FTC is sufficiently resourced to contest every merger that comes its way. So if you look at the fraction of mergers that the FTC contested recently, it's really a tiny, tiny sliver of what is out there. So I think the opportunity with HPC leading on this for citizens of Massachusetts is really tremendous. Now, while we all like to talk about hospital mergers, I think something that's equally important going forward is mergers in the insurance industry. And so let me spend a little bit of time talking about that. Mergers in the insurance industry are often justified by using the following kind of logic. The logic goes something like this. Gee, we are dealing with an incredibly consolidated provider industry. So we need to be equally large, because it's only when we're equally large that we can negotiate the best rates from providers. So far, so good. The problem with being as large as the providers is that many of us think that there's too much market power in the provider industry. And so when we add market power in between plans on top of market power in the provider industry, all that happens is you get twice as much market power. There is no pass-through of those better rates down to the level of patients. So this is something that we're going to have to watch very closely in the coming years. This idea of thinking about competition on the plans. Now, what's very exciting about Massachusetts and the ACA is that for the first time in our history, we have actually introduced competition between plans because of the exchanges. So that's one reason that so many people are excited about the exchanges. The challenge with the exchanges is that sometimes you see competition between plans, but you don't see a lot of competition between products. So I think that becomes an opportunity for HPC to lead on, is to say that, like, are there more innovative plan offerings than the ones that we're currently offering right now? Now, the economist in me should say, well, wait a second, if these new products were really valuable, then the large self-insured employers would be demanding them. But I think that this is another opportunity or source of anxiety for the Commonwealth. Large self-insured employers have really not led in demanding more creative products than I would have expected them to lead in producing. And one reason for this may be that the HR departments of large commercial insurers are often very dependent on the brokers who sell them products to sort of advise them on what products to buy. And I think what's happened as a result of that is large HR departments have embraced every possible snake oil to save money. They've embraced high deductible health plans, they've embraced wellness, they've embraced consumer transparency tools. None of those three tools will actually save us money. I think that at the heart of this is the fact that brokers haven't executed their fiduciary responsibility to shareholders and to their employees. And while this kind of delinquency would not be tolerated in the financial services industry by brokers, it certainly is in healthcare. And I think this is another opportunity for HPC to lead on. The Obama administration and Senator Warren's office have tried very hard to undo this kind of status quo, and I think joining their efforts would be a source of great opportunity for the Commonwealth, because when the large self-insured employers finally ask more of health plans, that's when we'll see unbelievable innovation in this industry. Other opportunities. I think one enormous opportunity that is in front of us is the ability to encourage Mass Health and the GIC to move to full risk contracts, including the coverage of prescription drugs. And if those are not possible at this point, to think about using bundle payments more than we're using right now. The challenge to full risk contracts and bundle payments has historically been we don't know how to measure quality. So the worry with bundle payments is that we're trying to take on the problem of overuse, but we create the problem of underuse because providers find it easier to make money by withholding care. Now, Massachusetts, as a result of what's been happening at CHIA, I think leads the country in how we should be thinking about the measurement of quality. And let me just tell you about why this is going to be so important, and then tell you about what we're doing at CHIA, and Aaron's here to answer any questions. So here's the opportunity with bundle payments. The opportunity with bundle payments is to look at this slide, look at how much we spend on hospital care and physician care, and notice that about 60% of healthcare dollars get spent on hospital care and physician care and clinical services. The growth may be coming from that third bucket of prescription drugs. It says 11%. I think that understates the actual amount, because a lot of specialty drugs that are given in a hospital setting should actually be in the third box and not in the first box. So let me just round up and say prescription drugs are about 15% of all of healthcare spending. You can see, while that might be responsible for the level, as I showed you earlier, responsible for the growth, the level is really driven by what's happening inside hospitals and what's happening inside the quieter physician offices, which is where the opportunity with full risk contracts and where the opportunity with bundle payments may lie. I think for Massachusetts, there's an additional opportunity. We have many AMCs in Massachusetts. Many of them rely on large public subsidies, especially for things like graduate medical education. There might be an opportunity for us to partner with our AMCs to think hard about the challenges that Mass Health confronts, to sort of design alternative ways of delivering care for Mass Health patients. And I think that is a collaboration that we have not entered into, because we often think of the AMCs as getting money from the Medicare program, when the reality is that while they may get money from the Medicare program, the goal of those dollars is ultimately to improve the public's health. Now, given that most of the spending is in the top 60%, that's what bundle payments and full risk-based contracts would target. That's what we have to think about with Mass Health and the GIC. The usual pushback, and I was responsible for this pushback, 5 years ago I would have said that's way too premature. But the thing is, we have CHIA, and every time I go around the country giving talks, I use this slide from CHIA. CHIA is able to measure quality, including things like patient safety, at a level of detail that was astonishingly absent from the debate 5 years ago. So we're now measuring things like pressure ulcers and iatrogenic pneumothoraxes and perioperative hematomas and postoperative hip fractures and accidental punctures. These are the kinds of quality metrics that plans should have led on measuring a long time ago, but CHIA has actually shown the way forward on. But because we're able to measure the performance of the delivery system, and we're getting better at it every day, I think for the first time, we are ready to experiment with bundle payments and full risk-based contracting in the GIC and Mass Health before any other state in the nation. On bundle payments, I think the opportunity is mostly in cancer at this point. So let me share with you an experiment that United Healthcare led on. They created bundle payments with 5 oncology groups for breast cancer, colon cancer, and lung cancer. So they identified 19 different types of cancer based on tumor site, on stage, on HER2 status, whether or not chemotherapy is used. And they paid providers a single amount to treat patients with that type of cancer. And what's interesting about the United experiment is that if you look at what happened to total medical costs and compare it to what happened to chemotherapy drug costs, what we learned from the United experiment is that total medical costs fell by about a third as a result of moving to bundle payments, but chemotherapy drug costs increased by 180%. Now, the economist in me says, well, providers were allowed to do whatever they thought was right. If they thought that the chemotherapy did not work, they would have cut back on the chemotherapy. In this particular instance, they did more of the chemotherapy and less of everything else. But what we really care about is, did we save money and were patients better off? And as long as we save money and patients were better off, I think that we have an opportunity with ideas like this in the state. And I think the right place to start is bundle payments for something like oncology. So let me move on to my next slide. The third opportunity, going back to David Cutler's question about specialty drugs, is I think we are ready to start to explore moving Mass Health to a PBM-managed formulary, and this may be better than bulk purchasing. And I'm not opposed to bulk purchasing. I think there are many merits to bulk purchasing in Medicaid. The challenge to bulk purchasing is, at the end of the day, the way one gets the best discounts is by having a formulary. That's really the tool that one uses in a negotiation to drive costs down. So unless the bulk purchasing is essentially setting up a bulk formulary, in which case I think bulk purchasing may be tremendously useful, in the absence of us being able to do that, one of the things that we want to think about is moving Mass Health or encouraging Mass Health to think about a PBM-managed formulary. Even with, this would not require a Medicaid waiver, as many of you know. Medicaid statutes authorize the state to use formularies. The general rule is that states have to cover every FDA-approved indication, but a drug can be excluded from a formulary if the excluded drug does not have a significant clinically meaningful therapeutic advantage in terms of safety, effectiveness, or clinical outcomes. Texas uses a formulary, Tennessee uses a PBM, so I think that there are opportunities for us over there as well. And then finally, I think one of the things that we should all be thinking hard about is examining novel pricing arrangements with the manufacturers who are so close to us. So going back to where I started, Massachusetts is a crucible for innovation, not only in health policy, but also in the biopharma industry. And if I look at the number of manufacturers within a 3-mile radius or a 1-mile radius of where we're sitting this morning, the opportunity to partner with them on innovative pricing agreements for things like cystic fibrosis or muscular atrophy may be tremendous. I think the vast majority of them are interested in figuring out how to sell drugs that work. What they need help with is working with a state in giving them feedback on what's working and what's not working. So there might be opportunities for Massachusetts to lead in some key areas of coverage that are important to us in Mass Health, like mental health, like oncology, like cystic fibrosis and muscular atrophy, by essentially partnering with the providers and manufacturers in these communities. So let me start to wrap up, and let me end on 3 words of caution as you listen to the proceedings for the rest of today and tomorrow. So I think one of the things that you have been extremely skeptical of, and I encourage you to maintain that skepticism, is that we have to be extremely skeptical of all the something-for-nothing remedies. So we have to be extremely skeptical about the benefits of consumer price transparency, of wellness, of population health, in saving money in the next 5 to 10 years. These things may save money, like I said, but they're certainly not likely to help us meet the targets that we need to meet in the next 5 to 10 years. I think that we should not sort of lose sight of the fact that some of the less splashy alternatives, like thinking about provider market competition and plan competition, or lowering rates, actually save a lot more money than some of these other ideas. The second thing that we have to be cautious about is what's happening in the other states. So if you look at Sovaldi and you look at the restriction of Sovaldi reimbursement, I see something very troublesome. And it's not happened in Massachusetts. So Massachusetts, as you can see, shows up in yellow. We don't have these restrictions in Medicaid reimbursements for Sovaldi. Most states have been restricting Sovaldi to persons with advanced fibrosis, this is stage F3, or liver sclerosis, stage F4, which is inconsistent with recent recommendations. But the reason they have to restrict Sovaldi is because, well, they have the recommendations, but they're not thinking as hard about cost growth as we are, and we all know that Sovaldi single-handedly can blow the cost targets. The recommendations, the clinical recommendations, state that Sovaldi is indicated for all patients with chronic HCV, regardless of disease state. Because the therapy is curative, it improves quality of life, it slows liver disease progression, and reduces the risk of sclerosis, end-stage liver disease, and all-cause mortality. The recommendations are very clear that patients at highest priority for immediate treatment include those who are in stage F3 and F4. So I applaud Massachusetts for not doing the kind of short-termistic thinking that the other states are engaged in. But in the absence of sort of bringing that overall target into play, we will be under tremendous pressure to think about strategies like this. Other states are doing other things which are equally troublesome. They are now starting to require that you have to abstain from drugs and alcohol for a very large period of time before you get access to Sovaldi. Again, this is absolutely not consistent with the proven therapies. Let me turn my attention now to a cautionary tale around alternative payment models. We are currently engaged in a massive publicly financed R&D scheme on payment reform. And this is, but I think we should acknowledge what it is. It is mostly R&D. It may fail. So we cannot sit and say, well, the move to ACOs or the move to global payment will pay off. It may not pay off. The right answer may actually be to pay for payments at the level of episodes, or maybe the right answer is some sort of mixed payment model. I happen to think that this experiment is worth playing out, that we should stay the course on ACOs and medical homes and see that we should get it right. But this will take us a very, very long time to get right. And I think in the short run, a lot of providers will come to us and say, look at all the terrific things that we're doing with global payment. Look at all the terrific things that we're doing with population health. The reality is the current efforts on global payments are all built on a fee-for-service chassis. So as long as they're built on a fee-for-service chassis, they're going to fail, right? It's going to take providers a while to move the global payments, the things that we're calling global payments, into the kinds of things that people like David Cutler call global payments, which are very, global payments sort of, they might look like the same, optically, but simply calling something an alternative payment scheme doesn't really mean that it's truly alternative. So I think we have to be skeptical about providers saying, gee, look, 50% of our contracts are now alternative contracts, and so we are able to bend the curve. I think as long as they're built on a fee-for-service chassis, I don't think that the global payments of today are really saving that much money. Second, we're not very good at measuring the outcomes of ACOs quite well. So CHIA is very good at measuring outcomes at the level of particular lines of service. That's exactly right. That's exactly where we should be. It's another way of saying we are probably going to be a lot more successful doing things like bundle payments, perhaps bundle payments for cancer, perhaps bundle payments for orthopedics, perhaps bundle payments for a number of other conditions, than we will be doing global payments. Because for global payments, we need an organization like CHIA to be able to measure the performance of the entire delivery system. And we are really still in our infancy in terms of being able to do that just yet. My final slide is this slide over here. This is a slide that I think you're going to have to remember as provider groups come in front of you and argue the employment benefits of what they're doing. So I wanted to point out to you that if you look at employment in the healthcare industry, that's the green line, and it's increased as a straight line over time. So 40% more employment in healthcare in the past 15 years. The rest of the economy is the orange line, and you can see the rest of the economy actually suffers from those things that we call recessions. Healthcare does not. It is a recession-free industry. And while we often say that's wonderful because the recession would have been so much worse if it had not been for all those healthcare jobs, we have to remember every day that healthcare is not a jobs program. I'm not trying to be insensitive here, but every time we think about the employment effects of a hospital closing, we're asking a patient to pay more for their health care. We're asking someone to take home a smaller paycheck because of higher premiums, and we're asking taxpayers to pay more in the form of taxes. I applaud you for being relentless in understanding this reality. But I will say one final thing, is that the U.S. labor market is finally recovering, which is wonderful. And so this is really the time to start to think about the realignment of capacity in a way that we would not have been able to think about while we were in the depths of the Great Recession. And so I think that's the reason why you should be extraordinarily bold in your vision. And I will end with that thought. Thank you very much.
Thank you so much. You've sure given us a lot to think about, and while we're running a little over time, I did want to give my fellow commissioners an opportunity. So, Carol, you want to jump in first?
Thank you very much. That was really thought-provoking. I was interested that you seem to call or label wellness and population health management as, or population health as snake oil. And, well, I'm a pediatrician, so I think of wellness as functionality of people being able to achieve their potential in whatever age bracket or health bracket they're in. And I also notice that I agree that we don't know how to measure outcomes in ACOs, and I hope that we will develop measures that do look at functional health as opposed to, little hospital admissions and things of that nature. So I'm curious, why is it snake oil? How can we, what is the value of wellness and population health management?
So let me clarify, and I apologize for the confusion that I've introduced in using that term. It's a snake oil with regards to the argument that it'll save us money. It is certainly good for our health, and so we should be doing it. But we shouldn't fall, we should be very skeptical of the argument that because we're spending more on wellness and prevention, that somehow this is going to help us meet the cost target. It's very good for people, and so we should do it. But it's not something that's actually going to save us money in 5 or 10 years.
Is that right? Is that the time limit that's the
it's
problem?
a time limit. Yeah, it's a time limit. And we don't know. I mean, it's not even the case that I can tell you that it'll save us money in the next 20, 30, or 40 years, Hopefully, but that's the best evidence is that it's mostly hope. I hope you're right on that. But it's an extremely expensive thing to rely on. It's really insufficient. It doesn't give us a pass on all the other difficult things we have to do.
David, and then.
Well, that was a tour de force, so thank you. I want to tape it and show it to my classes because it's just amazing.
don't have to teach it.
That's right. I could just take a vacation then. So I want to turn to sort of specific recommendations about what we being the state ought to do. And I think I took two broad themes from your recommendations. One was that we should try to foster competition because competition will lower the rates that we pay and so on. So I want to ask you to flesh out a little bit more what we would do there. And then second is you said we should move into more bundled payments because they're more straightforward to manage and so on. And I guess I want to get you to comment a little bit on that and then just sort of open it up and say, have I missed any parts? That is, what else should be on our agenda as we think about trying to sort of squeeze out the stuff we don't need to make room for the stuff that we do want?
So let me start with the last question first. The thing that I don't know the answer to, but every time I look at all the terrific work we've done in this state, I think that we could actually show the way forward for the other 49 states on how you think about the treatment of patients with mental illness in the Medicaid program, in terms of, are there ways that we could design episode payments for complicated conditions like that? I don't know the answer, but I think that is an enormous opportunity. And back to Commissioner Allen's point, it's not only an opportunity to save money, it's an opportunity to improve health. And that's ultimately what we all care about. So I think that's the grand experiment that I think we should think about. It will require partnership with the leading providers in Massachusetts. Thankfully, there's many of them. It will require partnerships with PBMs because it may require formulary design. So that was the one thing that I didn't say. Mm-hmm. On competition, David, I think at the end of the day, there is no substitute to having intense hospital competition. It is the single biggest piece of healthcare spending. We hear narratives every day on how consolidation is necessary because it implies integrated care. Consolidation is not integration, and we've known that for decades in healthcare. If you really want integration in healthcare, what you need to do is you need to be part of a health information exchange, and most hospitals are not part of health information exchanges. So I don't think we should ever, I think we've got too little competition in healthcare, too much consolidation, and anything we can do to kind of, stop that, ideally reverse it, would be terrific. So that's kind of piece number one. I think one way to increase competition is to think about telemedicine. Are there ways in which we could encourage the GIC or perhaps Mass Health to experiment with telemedicine? Again, going back to Commissioner Allen's point, we may learn from time to time that the move to telemedicine improves health, but it does not save money. We might have to come back and have a conversation on what that means. Hopefully it improves health while increasing costs, but increases health more. But I think that telemedicine is a way to think about competition policy in healthcare. Most of all, though, what I worry about is competition amongst the plans. And, we're going to be seeing even less competition there. One question that we should think about is whether plan competition or a reduction in plan competition is different than a reduction in plan competition amongst the pharmacy benefit manufacturers. It's possible that competition in the PBMs is actually very different than plan competition, because the PBMs are essentially commodities, and a large employer or a plan could switch from one PBM to another on the turn of a hat. And that actually means that that industry is very competitive. And we want that competition because when a PBM negotiates terrific rates with Gilead for Sovaldi, we want to be sure that everyone in Massachusetts gets those lower rates. What I worry about today is that two plans may actually negotiate terrific rates with Gilead, congratulate themselves for that negotiation, but none of us see the savings in the form of lower premiums.
Can I, last question, Martin, you?
Yes, thank you. A very enlightening presentation. I want to follow up on your last point, because the other place where I heard you mention competition was among the health plans for innovative plan offerings.
Yes.
I wonder if you could just go a little deeper what you would consider to be an innovative plan offering by the insurers.
I think here again, I think Massachusetts demonstrates yet again how it actually led the nation, I think the world, in what innovation in plan offerings mean. And I'm thinking here about the terrific move to tiered plans that the GIC led the effort on. And my understanding of that effort was that it was extraordinarily successful with many of its beneficiaries. I think one example is to think about tiering not only providers, but tiering different technologies. So especially if the technology is unproven, like proton for prostate, it's not the case that we should say you cannot have it. What we should say is you're in a plan that will cover up to the value of IMRT therapy. If you want proton for prostate, you can have it, but you're just going to pay for it out of pocket. I think that kind of reference pricing around technology, only the unproven technologies, nothing that works. There's so much of healthcare where we have no evidence. I think there, if we start, we could show the way forward.
This is wonderful. Thank you so much. Thank you so much. And
Thank you.
Appreciate it. Get everyone know that.
So now, on behalf of my fellow commissioners, it is an honor and a privilege for me to introduce the Speaker of the Massachusetts House of Representatives, Bob DeLeo. Speaker DeLeo is a Suffolk Law School alum, so welcome home, Mr. Speaker, who this year celebrates 25 years as a member of the House of Representatives representing Winthrop and parts of Revere. And before being elected Speaker in 2009, he was chair of the House Ways and Means Committee. And myself, having been a former budget director and chief of staff for the House Ways and Means Committee, I will always have a special appreciation and fondness for the role that important committee plays in the legislature. Throughout his distinguished tenure, Speaker DeLeo has been an unwavering voice on Beacon Hill for high-quality, accessible health care for the people of Massachusetts. But at the same time, he has never forgotten the fact that failure to control the ever-escalating costs that employers and employees pay for health insurance risks the economic future of the Commonwealth. Speaker DeLeo was a major force behind Chapter 224, the Healthcare Cost Containment Law of 2012, that created the Health Policy Commission and is the reason that we're here today. And he was likewise a key player as House Ways and Means Chair in the passage of the landmark 2006 law that ensured health care coverage for all Massachusetts residents, as well as scores of other pieces of legislation in between that have defined how employers and citizens access and pay for medical care. And finally, his advocacy on behalf of health care has most recently manifested itself in his support of comprehensive substance abuse legislation to protect family and patients affected by the opioid crisis. So please join me in giving a warm welcome to House Speaker Bob DeLeo.
Thank you very much, Rick, for that extremely kind introduction. And each time he talks about my background, and I sit here and listen to some of the testimony, I always come to the realization of why I never ever asked to be on a health commission. A healthcare committee, I should say, in the legislature. Going from Ways and Means to Speaker for me was the way to go, I think. But I have to really congratulate all of you for the great work that you're doing today, and I'm sure you're going to be doing for the next couple of days, actually. And a sincere thank you to an old friend, David Seltz, and the Health Policy Commission for putting this event together. It's nice to see you, David. I always enjoyed David in the State House and always enjoyed to see what he happened to be wearing on a particular day. If you have the opportunity, ask him to show you his socks a little bit later. But as has been mentioned, I'm sure it's been mentioned throughout the morning, healthcare costs are one of the most crucial issues that are facing Massachusetts today and are becoming one of the most defining factors for our state's economy. So while I know that we're talking about cost on a macro level, I hope that over the next couple of days, you'll bear in mind the human element of this equation. Too often, paying for treatment can threaten a family's economic stability. Too often, people have to make unimaginable decisions about their health care. Do I pay for heating and food, or do I pay for this medicine? With that backdrop, I remain very proud of what Massachusetts has done to lead the nation in terms of health care policy. And I look forward to tackling the necessary challenges if we're going to enhance the position of preeminence. 3 years ago, the Massachusetts legislature passed Chapter 224 to bring the growth of health care spending in line with the growth of the state's overall economy. As policymakers, we all recognize the inevitable, that health care spending was swelling and would only continue to grow in the future. At the same time, we knew the growth in and of itself is not necessarily a bad thing. Massachusetts is home to some of the most world-renowned biotech cluster in the nation's top-ranked hospitals and health insurers. We specialize in high-quality care and innovation. And economic expansion in those areas means more jobs and more resources pumped into our local economy. I think that's in direct contravention to what the gentleman who spoke before me just said, but whatever.
That's right, that's right.
One thing I did catch. But anyways, our state was at a crossroads. We wanted sustainable growth that balanced the needs of our residents in our industries, our families, and our businesses. That's why we passed Chapter 224. 3 years ago, we set an annual benchmark of 3.6% growth and created the Health Policy Commission and CHIA to help us implement our law and continuously assess its efficacy. These two agencies recruit some of the best healthcare talent in the nation to Massachusetts and are helping us to achieve that benchmark. We met the benchmark in year one with 2.3% growth. And although this year's growth of 4.8% exceeded the benchmark, we're addressing the unforeseen issue and are hopeful as we move forward. I also want to thank the Baker administration for their leadership on this issue. As the state's overall health care spending has increased, so too have mass health costs. Each year it seems that mass health takes up a greater and greater percentage of our state budgets. I believe in the immense importance of widening the sphere of health care coverage, But I also believe that we should have a system that improves as time goes on. That's why this past summer, I created a working group on Medicaid managed care organizations to examine mass health costs and the financial pressure that the 6 MCOs in Massachusetts face. These organizations cover approximately 42% of Mass Health members, and it's imperative that we work with Mass Health to ensure their financial stability. The working group, which was chaired by Representative Jeffrey Sanchez, who I see here today, includes stakeholders with diverse perspectives from every corner of the Massachusetts healthcare industry. They recently finished a series of meetings, and I'm told that they reached consensus in their findings. I'm anticipating their report very soon and hope to work with the administration to implement some of those recommendations as it redesigns and restructures the Mass Health program. A more transparent and agile system will not only save taxpayer dollars and ensure residents have access to quality care, it will also position the state to tackle devastating and unprecedented issues like the current opioid addiction epidemic. It has been my distinct honor to fight for legislation that will improve care for those confronting addiction and behavioral health problems. Last year's landmark substance addiction law went into effect just 4 days ago. That law marks a sea change in the way we do business and lays the foundation for improvement by increasing access to care. It requires all insurers to cover medical detox and increases access to other necessary services that are often sadly and incorrectly deemed luxuries. I have heard time and time again about individuals wanting to get clean, going through the painful process of detox, only to lose access to health care and to relapse. It is my hope that our legislation will help end that painful cycle. 14 days of treatment is a step in the right direction. While we are continuing our work, just last week, we provided crucial funding to addiction programming. We are acutely focused on how the rollout of this law will affect cost containment. As we begin to see the impact, I want this to be the place where Massachusetts again leads. My door is open, and I'm imploring those of you here today to help the House find inventive ways to provide unrivaled yet sustainable treatment for those grappling with addiction. I'm particularly focused on looking at the substance addiction epidemic with a wide lens. Last week, I visited both a drug court and a hospital in Plymouth. I spoke with people in recovery and those helping them, judges, doctors, social workers, teachers, and law enforcement. There was an underlying theme in each conversation, whether it was with a police officer or the person they had recently arrested. Coordinated and collaborative care is what works. Massachusetts has an incredible legacy in terms of health care. Whether it's through life-saving research or insurance reform, we believe that health care is a right. Through the collaboration of the HPC, the legislature, the administration, and the industries represented here today, we will advance the legacy to better serve the state's residents. I want again to thank the Health Policy Commission. We are fortunate to have such bright minds and dedicated public servants working on this very difficult topic. Thank you for having me here today.
Well, that was just wonderful. I'd like the panelists for the panel to come up and be sworn in. It's not that we don't trust them, but yeah, okay.
They pay the Medicare.
To the best of my knowledge.
All right, thank you. And we're ready to move into the main portion of the hearings, which will have witness panels. As you've just seen, they've been sworn in by our Assistant General Counsel and will be answering questions. But first, before we move into the panel, and we've had a lot of different data points thrown at us already this morning, but to frame up each of these different panels, the HPC has prepared a few additional findings that we think may be of interest to this commission. So you'll find the slides in your presentation and on the screen. First, as Commissioner Cutler mentioned, and as the chair often encourages us to think about, where does Massachusetts compare to the country? And where we can make meaningful comparisons, we should always attempt to do so. Here we're looking at commercial spending. And what we found is that while our commercial spending did tick up in 2013 to 2014, we continue to have a growth rate below that of the nation. We see that this trend, and this is reflected in Executive Director Barros' comments, is primarily driven by low growth in hospital and physician spending. Hospital and physician spending accounted for about 1.1% growth in Massachusetts during this time. And inpatient in particular actually had a negative growth when we just look at commercial spending for inpatient care. However, when we look at other types of categories of service, we see very different trends. This is a Massachusetts and U.S. comparison specifically on prescription drug spending. And as you can see, we track very closely to the nation, although slightly above the nation with regards to drug spending in the commercial space. 12.5% here in Massachusetts, a key contributor during 2013 to 2014. So wanted to highlight these two national comparisons for the Commission's edification. And finally, we have a new analysis that we are presenting here today, which looks at Massachusetts' growth rate within pharmaceutical spending, but based on the different classes of drugs. And what we find is in 2014, oncology drugs continue to be the #1 therapy class as far as overall spending is concerned. But we see incredible growth rates across the board, highlighted, of course, by a 350% increase in spending related to Hep C drugs during this time. We know that this is not just a one-time event. We know that there are other drugs that are coming on the market specifically for cholesterol that have the opportunity to continue this trend moving forward. But did want to highlight these additional findings for the Commission, both in national comparisons and specifically within pharmaceutical spending, where we are highest classes and where we see that significant growth. So with those, I'm happy to turn it over to the chair, who will lead our first panel.
Thank you, David. So given that we have sworn in our panelists, I am confident that when they introduce themselves, they will be very accurate, both in their name and which organization they represent. So I will leave it up to you to introduce yourselves and your organization. We'll start with Steve.
Thank you, Dr. Altman. I'm Steve Boswell. I'm the president and CEO of Fenway Health here in Boston. That's a large community health center that cares for roughly 30,000 patients and is probably best known for caring for people with HIV infection. We care for about 2,300 people with HIV infection. We also care for a large number of LGBT folk, lesbian, gay, bisexual, and transgender folk here in Massachusetts, which raises specific issues that I'll talk about later. I'm also a physician. I've been involved in the care of HIV-positive patients for 30 years, so I'll talk a little bit about cost, expenses, and how that affects organizations like Fenway.
Bob?
Good morning, Mr. Chairman and members of the Commission. Thank you very much for including me today. My name is Bob Coughlin. I'm President and CEO of MassBio, a trade association representing 700 biotech companies, research institutions, academic centers, and other industry stakeholders across Massachusetts and beyond. Together, Massachusetts biotech companies employ more than 60,000 residents and continue to grow at a rate significantly faster than other industries in the Commonwealth, as well as outpace industry clusters around the globe. The secret to our success, the true lifeblood of Massachusetts life science cluster, are the small, early stage, and startup companies that spin out of our world-class academic institutions and venture capital firms in the greater Boston area. These are the companies that are inventing cures and breakthrough therapies for devastating chronic diseases. Massachusetts headquartered companies have developed therapies that serve 232 million patients in the U.S. and more than 1.5 billion patients around the world. Our companies have nearly 1,500 drug candidates in the development pipeline and are committed to providing patients access to the treatments and cures they desperately need. I'm excited to be here today and continue to be part of this conversation as Massachusetts continues to lead the country in defining the future of healthcare.
Well, Norm, you've already been introduced, but I'll let you do it again.
Thank you, Mr. Chairman, and thank you, Director Seltz, and thank you for the entire Commission for inviting me to speak today. My name is Norm DeShane. I'm the CEO of Circle Health, an integrated healthcare delivery system in the Greater Lowell area, and WellForce, a collective of value-driven, independent-minded providers, including Tufts Medical Center, focused on innovating in care integration, communication and coordination, population health management, and operational excellence for our clinicians. I thank the Governor for his reference to Lowell General earlier and his recognition of some of our success. And I hope that it's a hallmark of what we'll be talking about today in terms of changing the way that care is delivered in Massachusetts. Because there are major differences in provider systems and the models and the costs associated with those systems. And I look forward to discussing those.
Welcome, Jim.
Good morning, Chairman Altman. Thank you, and thank you to the members of the Health Policy Commission and Executive Director Seltz for the opportunity to speak here this morning. My name is James Roosevelt Jr., and I am the CEO of Tufts Health Plan. Tufts Health Plan has more than 1 million members in Massachusetts, Rhode Island, and beginning in 2016, New Hampshire. We are one of the only health plans that participates in every market segment, including commercial insurance, Medicare, dual eligible products, both over and under 65, and Medicaid. As demonstrated by the most recent rankings from the National Committee for Quality Assurance, we continue to provide exceptional access to care for our members. For the 2015 to 2016 ratings for private plans, Tufts Health Plan's HMO, POS, and PPO plans received 5 out of 5 points, a distinction received by only 10 other plans in the United States. Tufts Health Plan public plans received a 4.5 rating for its Medicaid plan, a rating received by only 9 other plans in the country. There was only one 5.0, that's in Hawaii, where I think they start with 4.5 and work up. Mahalo. Similarly, our Medicare Advantage organization has consistently received 4.5 stars from CMS. I look forward to this conversation about challenges to the state's cost benchmark, and I'm happy to answer any questions you may have.
Thank you. David, welcome.
Thank you. Mr. Chairman, nice to see you. Executive Director Seltz and members of the Commission, my name is David Siegel. I am the President and CEO of Neighborhood Health Plan. I've been President and CEO since February of 2015. Prior to that, I was the Chief Operating Officer since March of 2008. Prior to that, I spent 23 years at Harvard Community and Harvard Pilgrim Healthcare, holding a whole bunch of roles except for General Counsel because I'm not a lawyer and Chief Medical Officer because I'm not a doctor, but I did a lot of everything else. I appreciate the opportunity to be here today. A few quick facts about Neighborhood Health Plan. We have 270,000 Mass Health members, about 135,000 commercial members. Of the MCOs in Massachusetts, I believe we have 33% of the market share at MCOs for Mass Health, and we are proud that we are at the 4% number for commercial and fully insured business, kind of lagging behind my colleague from Tufts just a wee bit, but in our market segment, we think we're doing pretty well. We were founded in 1986 by the Massachusetts Community Health Centers, and we remain committed to a mission that focuses on diverse populations, high quality, and certainly affordability, which has been our hallmark and something we have strived for long before this process even began. So with that, I once again thank you all for having me here and look forward to the conversation.
Well, I want to thank all of you for your introductions and keeping us going. Let me start off, and then I'm going to ask my fellow commissioners for other questions. So you've heard from Aaron Burrows about the CHIA numbers, and of course you've been watching that we were at 4.8. And so what I'd like you to comment on, if you look at your own organizations, the underlying pressure here, how should we be looking at these numbers? You know, and I know Aaron didn't want to talk about the future, but we have to be concerned about the future as well, whether we've built a chassis that really can survive in the future as well. So as you think about your organizations, any comments, I'd like you to keep them fairly brief, but comments about today and also looking into the future, how you see things playing out. So if anybody wants to start off.
So I'll start. So I think from the standpoint of Fenway Health, I think I'll focus on HIV specifically because it's both an area of great concern to me as a clinician, but also as the CEO of the organization. So in one of my roles is to actually sit on the board of directors of the physician organization associated with our ACO. And a couple of years ago, when I saw what was happening with regard to the development of new drugs to treat hepatitis C, one of which you heard about earlier today, it became clear to us that this would have a very significant impact on our bottom line. Great for patient care. I mean, the old treatments for hepatitis C were tremendously difficult to do, often required repeated hospitalizations. These new drugs are extremely well tolerated, delivered for short periods of time, 2 to 3 months. So these are much better alternatives, and they cure the disease. So when we actually went and looked at all of the patients in our ACO who were hepatitis C infected, currently infected, and eligible for treatment, we came up with a number in the thousands. When we actually did the calculations, if we treated each one of those who was eligible, and it was a subset at that point who were eligible for treatment, it would have cost the organization $60 million just for the drug. So the impact that this has, when we've entered into contracts 2 and 3 years earlier in a global payment, without any real clear understanding at the time we entered into those agreements that these drugs would be available, puts providers in an untenable position. And the consequence of that are twofold. One, providers are basically forced to go out of business, or they're forced to actually make decisions that are not in the public health interest and not in individual patient interest. So they're not in the public health interest because think about the hepatitis C infection in the United States. There are roughly 6 million people infected. So if we were to make these drugs available, now we can treat all subtypes of hepatitis C. If we made these treatments available to everybody tomorrow, in 6 months, we could eliminate the hepatitis C infection epidemic in the United States. We're not doing that, not by a long shot. And in fact, because we're not doing that, we actually have large amounts of transmission of hepatitis C that are still ongoing. So in fact, the epidemic at the end of this will end up being much larger because we're not paying attention to some of these other aspects of care. And I would bring that up in the context of some of the discussions here this morning. The one piece that's not quite in the discussion is public health. So, bundled care is great when you're focused on people's acute needs. But we're talking about a healthcare system. We're talking about health. There's a big portion of the benefit of a healthcare system that you're not going to be able to measure. So if we don't incorporate those aspects of what a healthcare system should be, we will end up with larger epidemics, with patients that don't get treated, end up with end-stage liver disease, a horribly expensive and horrible disease to go through. So these are the kinds of things that I think really keep me up at night. So to give you a sense of how this affects a place like Fenway, so in 2013, Fenway, I'm tremendously proud of this organization. We actually have been in risk for a long period of time. We had a risk payment surplus due to both quality and total medical expense in 2013 of $1 million. For a community health center, that's a pretty impressive chunk of change. This year, we will be lucky if we get $100,000. Now, what are the reasons? They're twofold. One, we're treating the 315 co-infected HIV and hepatitis C infected patients that are in our care and taking the hit for it. We are also doing something called PrEP, pre-exposure prophylaxis. This is the use of a medication called Truvada, which is the current medication we use for this, to actually give it to people who are at risk for becoming HIV infected to prevent them from actually acquiring that infection. It is phenomenally effective, 98% effective. So we have 1,000 people. Right now, our health center has 1,000 people on PrEP at the cost of $10,000 a year.
Can I ask you just because I want to get everyone else rather than what you're saying is fantastic, and there are a lot of questions I would ask. I don't really understand what you're telling us in terms of that hepatitis C. Should we just give you all the money, or is the price too high, or I don't know. But hold off your answer until others get it, because I didn't quite get. I got your concern, but I didn't get why. So if anybody else wants to jump in on this question, David?
Sure. Just building off Steve's point as one issue around using the Hep C example, neighborhood health plan, like many other health plans in the mass health space, did see an enormous spike in the utilization and costs around Hep C. And we can use Hep C as kind of a poster child for other specialty drugs that may come along the way with similar characteristics. The public health opportunity is obvious. I think everyone stated that. I don't think I need to go over that again. But the dilemma is that the cost of delivering on meeting what is a miraculous public health breakthrough is not always encapsulated in what Mass Health is able to afford, given their budget constraints, which are constrained by tax dollars and other programs that compete. So I think from a public policy perspective, from our view, is we need to figure out how we're going to titrate that so the right people can get access to the right drug in a way that is sustainable. And that's the way I would put the challenge on the table. It's and there's a tendency to want to find a good guy and a bad guy in this kind of conversation, and I think you have to look really hard in this particular one to find anything like that. That was one thing that we observed. The other thing from a just general thing that we observed is Our concentration in the commercial market is really in the merge market and a lot of things that happened as a result of the Affordable Care Act. And there were many puts and takes on this. But one of the things we found in both the mass health space and certainly in the connector-based space is the population's moving around. It's not like you could look at the population that was here and say they're going there, so we'll understand what their costs were. There was kind of things that came out of the woodwork, so to speak, that the costs just rose, and we weren't quite sure what happened. My point on that is what will help us in the future is a few years of stabilization so that we can understand those populations and kind of recalibrate what it is that we have to do. Those were probably two of the biggest things that we experience, in addition to, things that insurance companies go through, one-time payments for this and certain adjustments we had to make for that. But those were some of the big drivers that we experienced.
All right, can I ask the other panelists in commenting, I think we understand the drug issue. We don't understand what to do about it. But if there are other areas that you want to focus on, that'd be great. Jim?
Thank you, Chairman Altman. I think Steve and David have both highlighted what is the value added of insurers in this equation. Because insurers are required to maintain reserves, because insurers develop care management policies, we focus on meeting the unexpected highs in costs. We also focus on what therapies are proven to be effective. And we are able to absorb some of the risk, some of the problems that providers in other states have faced in dealing with these questions. I completely agree that bundled payments are only a tool. They do not address overall health. They do not address public health overall. More comprehensive global payments get us much further toward that goal. So I think we have to be careful not to focus on any one tool. Even transparency, which I think is very important as a tool, is only that. It's not a solution. It gives us information for designing tools. So the challenge that we're facing on prescription drug costs is a national one. I think we can further the discussion by promoting transparency here on prescription drug costs. Again, I think there is pending legislation nationally for greater transparency on drug development and R&D, as well as marketing and profits. All of that, I think, is going to go toward trying to continue to solve our problem of meeting the cost benchmark here and nationally.
Thank you. Norm, and then Bob, if you want to.
Thank you. I think that I applaud the efforts to put a benchmark in place because we needed to do something, and I think it was effective, and I think the results have been effective for the last 3 years. And I also I'm at the same time very concerned because the benchmark, like anything else that's related to freezing rates or controlling rates, bakes in some of the problems with the system and doesn't change the system and the underlying system. So in case of my institutions, it baked in significant market inequities in terms of rate differences between various hospitals across the state, and I think that's been well documented, especially by the Attorney General. And I think overall it also creates pent-up demand. So we have kept the lid on things, and we've done a pretty good job for the first 3 years, as evidenced by the results. But during that same time, those pent-up costs continue to grow. Labor costs, pharmacy costs, and others that that the industry itself can only absorb so much. And as we continue to look for innovative models, and we're relentlessly pursuing those kinds of things, and we have to build and change the chassis. And I agree with the governor's assumptions about trying to build a new system on an old chassis. We need to change the underlying chassis, and that's happening. It's happening in many communities and many provider organizations, but it is a significant, it's a major retooling, if you will, of an industry that's still has payment in two different places. And I would encourage that the faster we move towards alternative payment methods, the better we'll be. In my first 5 years in the Blue Cross alternative quality contract, we saw a 75% increase in quality, and at the same time, we averaged an annual increase in cost of 1.6%. It's a really retooling, and I think it's something that is a lot more in-depth than something that's just a rate that's put over the top of an industry, and everyone thinks that solved the problem.
Thank you. Bob, I know you have the enviable or unenviable, depending on which way you look at, task of defending an industry that's doing phenomenal, keep me alive. On the other hand, sort of bankrupting a bunch of these plans. So,
well, it depends on how you look at it, Mr. Chairman, but it's an honor to be here. I feel very comfortable amongst these esteemed fellow panelists. You did ask, Mr. Chairman, you said, what is it that we think about at our own organization, in our industry? Well, I'll tell you what we're thinking about in the biopharma, the innovation industry. We're thinking about how can we continue to bring value to the healthcare system? By value to us, it means how do we invent breakthrough therapies that change the lives of patients? How do we invent breakthrough therapies that are actually going to bring value to the healthcare system and remove cost elsewhere? And it's great that we're having this discussion now, because there will be more breakthrough therapies down the road. Let's hope that there are. When we talk about things like gene therapy and CRISPR technology, there are going to be more cures. And we have a healthcare system that is, the reimbursement and payment systems are aligned with treating ongoing chronic conditions, not potential cures when the costs are front-loaded. So it's so important. We're going to continue to focus on diseases like cystic fibrosis and Duchenne's muscular dystrophy, but we also should be focusing on larger indications like Alzheimer's and cardiovascular disease. And we'll continue to do that. So I think we can control our own behavior by continuing to do the right thing. This industry does not want to be lumped into a category of people that bring financial innovation to the industry, Wall Street folks that will change the price of a drug that's been generic for many years, and I'm sure we can talk more about that. We want to focus on being part of the solution. How can we show that these drugs avoid cost elsewhere, and how can we manage that over the life of a patient?
I'm going to turn this now over to my panel and my deputy here, who's running the show, really.
Thank you. Bob, one of the things that's been interesting to me and surprising is how surprised providers and payers were when Sovaldi hit the market. And I think it goes to Dr. Boswell's point about this was unanticipated. People are, in a tongue-in-cheek way, referring to the new cardiovascular drugs as the pesky nines, because nobody can quite remember the order of the letters. Bob, I'd be really interested in how you think the council could work hand in hand with payers and providers and to really get people to understand what's coming down the pipeline so that this surprise element disappears. The pipeline is no secret. If you spend any amount of time looking at what the drug companies are doing, particularly the biotech companies, you know a year in advance what's going to be coming on the market, and if it's a brand name new breakthrough cure, it's going to be pretty expensive. How can we shift this dynamic of kind of particularly in specialty drugs and breakthrough cures of this surprise element so people can start to prepare for how they want to deal with these drugs? What role can the council play? And then I'd be interested in hearing from other panelists as to how you might do this, and to some degree why it was a surprise.
through the chair, I don't think it should be a surprise to anybody. You're correct in saying that we know where drugs are in clinical trials. We know that they're coming. It was no mystery that this was going to be a huge improvement over the current treatments available. And I think what we need to do, and not just, especially as we move towards gene therapy and other potential cures, we have to have the conversation up front. It's not really a cost issue. The way the pricing for these drugs is developed is based upon current treatments and where the value lies from this new existing treatment. It becomes more of financing than reimbursement. This was front-loaded. How do you manage paying for such a wonderful breakthrough therapy over the course of an extended time period? Those are the type of discussions that need to take place. Many of the member companies here, and Dr. Chandra talked about it earlier, that where industry is talking with payers, can you do this more of a value-based payment? These are the type of discussions that need to happen, because again, if it doesn't bring value to the healthcare system, they're not therapies that we want to be inventing.
David?
I just make one brief comment to respond to your question. Like many organizations, we have a pharmacy benefit management company that's watching the pipeline. We have our actuarial company that's watching the pipeline. Our parent organization over at Partners is watching the pipeline. I don't think what surprised us was as much the drug. What surprised us was the cost of the drug. That's where the surprise was. And so as we think about, well, how do we deal with that? That'll help, I think, solve a lot of the mystery around it.
And just to follow up on that, when we were surprised by the cost of the drug, because it was public knowledge what it cost the seller, Gilead, to buy that drug from the original developer, and that was made back in less than a year. So it wasn't related to the cost of development. That's why it was such a surprise.
David?
I want to ask two questions. One is hopefully very quick, which is, do you have a guess, particularly for the payers, David and Jim, do you have a guess as to whether 2015 spending is likely to come in above or below the 3.6% based on your experience so far to date? And then the second question is, I think, for anyone, which is, you've sort of hinted at changes you'd like to see. So, Norm, you said that we need to be more rapid in terms of use of alternative payment mechanisms. And, Steve, you mentioned that we need to write different kinds of contracts with regards to pharmaceuticals and so on. I wonder if you can fill out a little bit more with specific suggestions that either HPC or the Commonwealth ought to pursue along these lines.
I'll start if you want,
Please do.
Professor. Managing total medical expense continues to be the goal here. And if you take prescription drugs out of it, in our case, trend would have been 1.8%. So I think continuing those efforts provide us a good shot at meeting the benchmark in the coming year. But I do think that the cost of pharmaceuticals is the big unknown here. We've already heard about some others that are in the pipeline.
I would have a similar comment. We were over the benchmark, and we had in 2014 in our commercial business, we had some one-time things that will not repeat. But when you take those out and you focus on the fact that we have a 1 to 2% margin improvement program in the commercial space that we're driving towards, and a 4 to 5% margin improvement plan in the Medicaid space, we think that we will come close next year to the 3.6% or to the benchmark next year. I can't say whether it'll be a little bit below or a little bit above it, but we expect to that we will be close.
One more answer to that, and then we'll go on. Okay. Yeah, Doctor.
I don't have a specific answer to the big pharma problem in terms of cost of drugs. I do think that there are opportunities on the table with regard to certain kinds of discounts. The VA has significant discounts. 340B program has significant discounts. Medicaid could, potentially work with 340B providers, dish hospitals, and community health centers to figure out some way of trying to share in some of those savings. But the big concern around the cost of pharma is the growth from year to year. And I tell you, as a physician, you ain't seen nothing yet. In the next few years, you will see amazing technologies, and the costs will be beyond the roof.
Do your risk contracts include pharma? That is, you're at risk for pharma costs?
Yes.
Rick?
Yeah, when the governor was here, he mentioned one of the challenges in meeting the benchmark is going to be the demographics of our population, which is aging and baby boomers getting into their 60s. I wonder if any of you could comment on that in terms of challenges that we're going to face going forward.
Norm?
Yeah, I think that that's something we see, and it's something certainly in the low market where there is a variety of socioeconomic pressures on the population, both in terms of drug use as well as other issues. And I think going forward, some of the things I might talk about is moving more from volume to value, having the state and perhaps this body and Mr. Boris's organization look at the variation in provider populations that they serve to better understand the impact of healthcare disparities within communities and within socioeconomic groups. Certainly, there are differences from city to city and town to town, and we see and we think that there's value in having population health metrics so that communities and organizations and providers who serve a more challenging population be provided with higher reimbursement to deal with those populations than in other parts of the state. And I know this creates some inequities, but at the same time, those inequities currently exist in the opposite direction.
Mr. Chairman,
Yeah,
if
sure.
I could just say, one of the reasons that we at Tufts Health Plan are in all of the spaces is this factor of demographics, because there are many forces at play here. For example, in our managed Medicaid products, we do have an increasing population because of demographics. I think demographics are one of the reasons for Medicaid enrollment growth overall, because only Medicaid covers nursing home and at-home care for homebound people. On the other end of the spectrum, getting everybody covered has lowered the cost for qualified health plans on the connector, as well as legal immigration lowers that cost as you get younger, healthier populations. So I think demographics is a complicated question here that we're going to have to pay attention to, but it doesn't all go in one direction.
Paul?
In this innovation space where it includes things like Sovaldi that, are very effective, they have public health value, and they have savings discounted in future years probably for hospital and physician costs that we're going to forego if people get treatment, all the way through things Dr. Chandra talked about, proton beam therapy or some of the robotic surgery or drugs that are offered to patients that may be very expensive and for only a small cohort, maybe increase life by a month or two. And so my question is, under that banner of innovation, who should be deciding the employment of those offerings? Should we leave it up primarily to the provider community? Should we look, Jim spoke, at insurance companies add value in this space? Do we want government or groups like ICER, private nonprofit groups who we defer to create standards to guide this? Who should we be looking to in order to get value, which is the operative word that I heard people talk about?
Well, I think ICER is a start to come up with pricing that shows the value of that new product. One of the things that I find interesting is that we constantly talk about the price of pharmaceutical drugs as it relates to the overall cost of health care, when in reality, I mean, studies will show it's anywhere from 10 to 13% of the overall cost of health care. It was in the mid-50s, and it is today. Granted, healthcare has gotten more expensive, but the prescription drugs are still around the same percentage of that
As
overall
Dr. Chandra
cost.
notes, it's a little bit understated because some of that is absorbed into the Part A hospital costs, et cetera. You know, we pay physicians the fee plus a 6% add-on in the injectable oncology space or for ophthalmology. So I think your number's a little bit lower than the reality here.
Yes, and I am mindful that we're under oath up here, so I'm going to say approximately. And, you know, for even, let's say that it was approximately 15% of the overall cost of drugs, and we cut drug prices 20% across the board, not just new therapies, but all therapies, it would still only reduce the total healthcare spending by 1.5%. The real opportunity to bend the cost curve here remains in other categories of healthcare spending, not just with prescription drugs. Drugs already have, medicine's the only part of the healthcare system that has built-in price reduction already when medicine loses its patent exclusivity and becomes generic. You know, and that's why drug spending has stayed at that 10 to 15% area.
So I'm a believer that all healthcare is local, and it's really about the relationship between a practitioner and the patient. And as was evidenced by one of the speakers who showed a slide that said overall spending went down while at the same time oncology drug use went up. I think a change in the way we pay for care and truly creating that value and allowing our practitioners to make the best decision for what's best for that patient in that particular setting and that particular time at the right cost. And one of the differences that I've seen over the last 5 years in Lowell has been allowing our clinicians more latitude, not less latitude, to take advantage of the risk-based dollars that we get. And they've made better decisions, better care, as evidenced by the quality scores going up and the costs coming down. And I think trying to do this on a macro level sometimes really misses the point of how care is delivered.
I think that's great.
Thank you. We heard the governor this morning and more recently the Speaker of the House talk about the opioid crisis. I'm wondering what your thinking across the panel is around behavioral health as it relates to the benchmark and sort of, if you look into your crystal ball, what you're seeing in the coming year around behavioral health as it relates to costs.
I'll start. We at Tufts Health Plan have been a longtime believer in managing behavioral health and physical health in a coordinated fashion, and we think that's very, very important for overall health and thereby for overall cost. So I think the more that we can move to that in the system, we will have better results both on outcomes and on cost. It is likely that behavioral health costs are going to go up. We are looking at not just things like the opioid crisis, but just overall mental health needs in our society, including here in the Commonwealth. And we are looking at the need for higher payment rates for some of those providers to make sure that those resources are available. So that's going to have to be an area of focus in our overall approach.
Just to build on what Jim was saying, neighborhood has always had a very integrated approach to behavioral health. Our medical care managers sit right next to the behavioral health care managers, which in fact sit right next to the social care managers, to have a very integrated approach to that. We certainly have embraced the chronic care model of opioid addiction and have been working very closely with the secretary and her team and many others throughout the state, our trade association MAP, to really kind of have a more integrated approach to delivering that, focusing this as a chronic disease, not as a stigma that should be ignored. And I would say that specifically for us, we have just implemented a serious mental illness program. And it's really a pretty innovative behavioral and medical approach where we're really creating a behavioral health home in combination not just with traditional providers, but also with community mental health centers in the Commonwealth.
Thank you. I have a different topic. Last year, when we were having the cost trends hearings, on the first morning, Medicare announced its avoidable 30-day readmission rates. And as I recall, we were tied for fourth worst in the country with New Jersey. I'll speak and look to Aaron for this year's numbers, but as I recall, they're not much better. Slight improvement, but we're still in the cellar. So we obviously haven't made much progress in figuring out how to discharge people from hospitals in such a way that they remain out of the hospital unless it's really medically necessary. I know that this isn't the panel of folks who are all running hospitals and could speak to this, but kind of as a combination of hospitals and health plans, what can you do to move us up the scale so next year we're not having exactly the same conversation? And or what advice would you give to the commission to help us move the needle on this particular issue? It's an incredible waste and an incredible waste in the state that we shouldn't be tolerating.
Thank you. It's a very good question, and it is a challenging issue. And it's one that hospitals have taken very, very seriously, and I've worked really hard at. But I think we found that there are, again, some socioeconomic issues and some baked-in issues in the system that are creating problems. And again, it gets back to how the payment structure exists in this industry. And a move towards and away from the way we care for patients using the hospital as the physician of last resort, and changing that model. And as one of the things that we're particularly proud of is one of the HPC grants that we received is really focusing on the 5% that the governor spoke about, and focusing on how to care for that 5% with chronic disease and continued recidivism. And we're very hopeful that with funding that we received and the restructuring and retooling of some of our delivery system in the Greater Lowell area, we'll be able to have a true impact on that, because there'll be other systems to support those patients, a true team approach in that regard rather than a sole practitioner.
I support what Norm has just said, but being from the payer side, I want to particularly emphasize what he said about changes in payment methodologies. The more global your payment, the more you remove the wrong incentives to discharge patients too soon, the more you create incentives to have personnel, probably non-physician personnel, following the patient, making sure that they're taking the right medications and taking their medications, answering their questions, and guiding them to not get readmitted to the hospital. And you even remove perverse incentives, such as moving patients from acute care to provider-owned nursing facilities, when it might be better for them to go home or to stay a day or two longer in the hospital. So again, payment models that are global and that align incentives are very important here. They're not the way it's delivered, they're what encourage the right delivery.
Okay, I want to make sure I get everyone who has raised their hand.
But I just want to follow up on that, Jim. What are you doing with regard to your PPO enrollees and alternative payments?
So this is a topic we discussed last year.
Yes.
And we think we are making progress. We are using some methodologies to attribute primary care physicians from claims data to PPO members. In particular, we are modeling with the Group Insurance Commission the integrated risk-bearing organization approach, which is the GIC's term for PPO with primary care physicians and referrals. Another name for that is POS, point of service plans. So we are making progress on that. It is not, as you know, simple. And there was some conversation earlier when the economist was speaking about what the national plans do versus what we do here in Massachusetts. We are more innovative. He mentioned our tiered products, for example. I firsthand, I've talked with large national employers about the fact that they can't get a tiered product from their national coverage. I like to say to them, of course, one solution is offer regional plans. And that's not just an ad. I mean, in California, for example, national employers will offer Kaiser alongside Cigna, let's say. So offering alternatives that are more coordinated care. The reason they offer them in California is very popular with employees and cost savings with good outcomes.
But do you have a timetable for when you'll offer them, for when you'll move your PPO patients?
I can't say we have a specific timetable. We have a work in progress.
Paul?
Jim, if I might just to build on that, I'll give credit to Tufts. In our 2014 data, they were the only plan that had any members in a PPO-based global payment arrangement. It was with the GIC work, but they are ahead of actually other Massachusetts in that.
And I will say there is a timetable in the GIC RBO program. In fact, there are penalties that we pay if we don't meet that timetable.
It would be nice to see it branch out, though, into the non-GIC.
And we've begun that. We have begun that, but
that's great.
There's definitely more to do, and these annual meetings encourage us to do that.
So what can we do to encourage the other plans to do that?
I think those nice compliments help.
Go ahead, Paul.
Since we're on the pathway of frustrations with insurers, let me add to that mix. One of the great frustrations, at least that I have, maybe other commissioners, is when we say to Aaron, gee, we're seeing, the plans give us their TME, can we compare across plans? He says, well, we can't because they don't risk adjust in a consistent fashion, okay? And from a policy commissioner standpoint, thinking about, how our plans, working with providers towards greater efficiency, you want to make that comparison. So when I read you and your colleagues tell us, we need the flexibility, we have to do our own methodology, help me to understand why.
So I'll break ranks on that. You might notice that last week, the Mass Hospital Association and the Mass Association of Health Plans agreed to a standard set of quality measures for tiered plans. Okay. I think that kind of an effort on risk adjustment would be very worthwhile. And yes, in the short run, we always argue for flexibility because it's work to get to something that works for everybody. I think we got to work toward it.
Would you say I'm right on the policy side, then, is what you're saying to me?
I am.
Okay.
So if I may, I have a reputation I have to live up to, so if I'm too agreeable, people won't think it's me. But I agree with Jim. I think we need to define, are there explicit objectives we're all trying to achieve with this risk adjustment and make sure that we are able to achieve them. If that is the case, moving towards a more standard risk adjustment seems like a very reasonable thing to do. And if I could just put in a quasi-plug or unplug for the last comment about PPOs, we do not have an attributable PPO product because we have only 500 members in a PPO. So we're not doing it because we really don't have any members, just for the record.
Let me go back to the discussion about drugs, prescription drugs in particular. And I want to really thank Bob publicly for the way you presented this. And let me quickly summarize what I thought you said. And if I didn't get it right, let me know. What you said was we should be focusing on making a difference in the healthcare system, that these new drugs should add value to the delivery system. And you also were in support of the ICER organization. For those of you who don't know that organization, they are trying to balance new innovations with value. And one of the first, by the way, to question the proton beam. But what they do in their new activity is to look not only to look at the total ability of the system to afford a drug as well as the individual. And I think that's a major breakthrough. So I would ask all of you, if as we look at going forward, and we really take seriously this word value, how do we interpret that? Can we rightly say to a particular drug manufacturer, you've come up with a very interesting drug that really doesn't add a lot of value to our system, but is priced very high? How do we deal with that? I actually think Sovaldi is the opposite, where it added tremendous value, thanks, doctor, to the delivery system. And yeah, it was expensive, but over time, we're probably going to pay ourselves back versus drugs that are going to come online that, whether it adds a month or 2 months, but at very high price. How do we deal with this value issue? As Dr. Hatter said, it's the new buzzword, but when you really get right down to it, it's not easy to really deal with it. So anybody want to jump in, Bob?
Mr. Chairman, could I just start, because I want to state for the record that the ICER approach to determining value and pricing is a wonderful start, but it is a work in progress, and it's wonderful that that discussion is taking place, and industry looks forward to being a proactive part of that discussion with them. And with that being said, I think that when you look at a situation like Sovaldi, the existing treatment was $100,000 and extremely toxic. So we were able to show, ICER did show that that is a high-value drug. The only way that you can really track costs avoided further down throughout the life of the patient, if, currently payers and PBMs are incentivized to manage short-term costs, they may not be covering the same patients down the road in order to recognize the savings. So I think we need to take a look at that. And that's the only way we will be able to accurately track costs avoided with these new breakthrough therapies moving forward.
So as a physician, I'd say the value of any particular drug can never be discussed outside of the context of its use with a patient. So, and in that context, I think primary care is the critical piece to the healthcare system. In my view, as a primary care clinician, you have to have basically a relationship with patients, a long-standing relationship, and you have to have a relationship that's taken them through multiple episodes of illness involving different organ systems. And in that context, you build a level of trust with them, and you can have levels of discussion that allow you to yank out of the system huge amounts of unnecessary care. And that's the bottom line. And if you don't support primary care, if you don't, remember right now, the way we're currently funding things, we're doing these global payments. Policymakers don't want to be involved in actually deciding how dollars are allocated within the system. I totally get that. But to totally divorce yourself from decisions around that support certain designs of the system, supporting primary care, I think is a mistake. So subcapping systems. I sit on a board of directors with other physicians. I am one of 6 primary care docs. There are 27 members on the board. If decisions about how we organize ourselves are made at those meetings, whose opinions are reflected in those decisions? It's not primary care. So if you want primary care to be the center around which we build a stable, thoughtful healthcare system, you have to figure out how to fund that system, and it's got to be at a higher level than it currently is.
So,
primary care expert.
Primary care, yeah, yay. Let's hear it for primary care. I have actually 2 questions to follow up on 2 of our commissioners' questions. The first one is about behavioral health again. To follow up on Marty's question about the sort of the future, I guess I would like to know from the providers at the table, how do the impact of carve-outs on your practice? So, and then to hear from the insurers. So, when you're taking care of a patient, whether they're behavioral health is integrated into their insurance product, or whether there's somebody separate dealing with it. Does it make a difference in how you care for the patient? And especially as I agree with you that it's all about relationship and trust. And part of that, so primary care is providing a lot of behavioral health treatment. Don't think that it only sits with behavioral health providers. So and what is the impact, and what do you think we should be doing with our insurance products around behavioral health? And then I have a second question.
Well, as a provider here at the table, I think behavioral health is critically important. It's a huge portion of what we do and what many community health centers around the Commonwealth do. It is our most demanded service, quite honestly, and I would bet that's true of every major academic medical center as well. The problem is it's not paid well, so it's hard to sustain it. So my job is basically, I hate systems that are different by insurer. The care that we should be providing should be the same regardless of who the payer is in a system. So part of my job is actually to insulate all of my providers from all of the pressures of this crazy system that we live in, trying to provide seamless integrated care for our patients. So, we have a Suboxone program. We have, and I just want to add one thing. I know the governor made a comment about the opioid epidemic, but I just want to remind everybody, because I'm now old enough to have been around when that started. In the 90s, if you'll remember, primary care and doctors and clinicians in general were chastised for not providing pain management.
That's what I said
I cannot tell you how chastised we were. So when that comes from on high, don't be surprised if you end up with an outcome that has problems on the other end. So there's nothing new about the fact that opioids are problematic, but they are tremendously useful in certain circumstances. And where it's not a black and white line, so where that goes gets moved a little bit by pressures that are put on the system. So I don't put some clinicians who were trying to influence that process out of that problem. It was really not entirely clinically focused, in my view.
I need to bring this to a close, but I really want to thank our panelists. I want to make sure that everyone has had a chance.
Insurance, wait a minute.
Oh, there was this.
Sorry.
Did I hit the second?
Well, if they have comments about carve-outs as well, the insurers, I'm sorry.
So actually, we're not the ones to talk to about carve-outs.
I think you're going to get that opportunity.
Okay, we'll talk about it later.
On later panels.
You get an opportunity.
They'll tell you about some ways those can be managed. We
do have. We wouldn't call it a carve-out, though. By any stretch of the imagination, we really do seriously refer to it as our integrated behavioral health partner, and it's for the reasons that I stated earlier. Beacon Health Options staff are co-located. Programmatically, we do things in a consolidated program. It's not like we have a behavioral health program over there and a social and medical program over here. We purposely put them in the same place. They're part of our overall clinical teams. They go to the same meetings. They're engaged in the same kinds of treatment planning as one unit.
Okay. That's a good answer. We will discuss that more at the panels. But again, I want to thank this panel. I think you hit all the right buttons and all right, now we are going to break for lunch. It is now 25 after. If we can get back here by 1 o'clock, I would really appreciate it. So thank everyone, and we will see you at 1.
I think so.
Right now?
Sure.
Okay.
Good to see you too.